Okay, so we are on our last lecture today, last class, and we are going to be finishing up the book with specialized dentistry. The abbreviations down here are lingo or jargon in the business in dental for the different specialties that we discussed way back in the very first class. So we looked at specialties back in the first class, and we looked at periodontics, or perio, endodontics, or endo, oral and maxillofacial surgery, or OMFS, pedodontics, or pediatric dentistry, pedo, and orthodontics, ortho. These are the more likely way that you're going to see people refer to them in the business, so I put the jargon here so that we can get used to speaking it and seeing it. Okay, so this is week 10. All right, we're going to start with periodontal disease. And periodontal disease is the leading cause of tooth loss in adults. 75% of adults have some form of periodontal disease. That's a lot of teeth at risk for loss. My favorite thing, as we saw on the prevention video, is only floss the ones you want to keep. And this is something that you can tell your patients. It's amusing. It tends to break a barrier, and it really gets the understanding there. So we don't want to lose our teeth in general. Most of us don't want to lose our teeth. And so this is a way to reach our patients to get them to understand why we harp on flossing. Why we harp on prevention. So let's describe periodontal disease in the mouth. Now, we described periodontal disease a few weeks ago as a bacterial infection that is caused by plaque. Periodontal disease is also transmittable, which means that you can catch the disease from others. When we talk about the description here, we're talking about how we describe the mouth in its various states of periodontal disease. So I can say that 75% of adults have periodontal disease, but not all of them may have severe periodontal disease, and not all of them may have all of the teeth in their mouth involved in periodontal disease. So there are degrees of this, and we describe them as slight, early, moderate, severe, or advanced. Severe or advanced being the same. So how severe is the disease in the mouth? This, and we're going to talk about this in a moment, this is usually decided upon by the depth of the pockets in the mouth. So we're going to talk about that in a minute. Localized or generalized, how much of the mouth is affected? So I can have a localized severe around one tooth, and I can have generalized slight around the rest of my teeth. So see how we use these descriptions of where in the mouth it is and the degree or severity of the disease. What is affected? The periodontium is what is affected. What is the periodontium? It's what holds our teeth in. What holds our teeth in are the gingiva, the epithelial attachment, and that means that where the gum joins the tooth, that's the epithelial attachment. So are our gums attached to our teeth? Yes, they are, or at least they should be in health. The sulcus, which is the place where your popcorn kernel gets stuck. So your sulcus is the space between your tooth and your gum. It's where you put your floss. And then PDL, which we learned about way back in the first class or two. The PDL, or periodontal ligament, is sort of the trampoline that our teeth are on. So every time I bite down on something hard, my teeth absorb that shock because they're on a little trampoline or a ligament that helps them absorb it. Cementum, which is the outer layer of the root that we expect our structures of the periodontium to attach to. So cementum has to stay healthy. And alveolar bone, which is ultimately what holds our teeth in. The periodontist is the specialist that deals with periodontal disease. The disease process, what does it look like? And some of this is review, but we want to just make sure that we're on the page of what we're talking about here. Red, swollen, tender gums. There tends to be pus in places. I say malodor because there is a definite smell to periodontal disease, and the longer you stay in the field, the more you recognize it on first. I almost want to say that it's marshy. So if you've ever smelled the marsh near the ocean, that is reminiscent of it, although I have to say that I live near the ocean and I love the marsh. So I wouldn't call this a smell that I love. Periodontal disease is not a good smell. It's a disease. It doesn't smell good. Gingivitis is the start of periodontal disease. This is reversible. What do? Remove our plaque daily and get regular cleanings. That's how we reverse gingivitis. Periodontitis is the progression of the disease into the alveolar bone, into those structures that support and surround the tooth, the periodontium. What do we do about periodontitis? We can do surgical therapy or non-surgical therapies. Generally, we start with non-surgical, so we start with the least invasive to see if we can get reversal, or I shouldn't say reversal, I don't mean reversal, to see if we can get health. Why is periodontitis not reversible? Because you can't grow the lost tissue back. So if you lose gingiva to periodontal disease, if you lose your gum tissue or you lose your bone tissue to periodontal disease, it will not grow back. I can make the disease stop, so I can make it not get worse, but I can't bring it back. And this is why flossing becomes so important and plaque removal becomes so important, because there is a point where we can, once we begin to lose tissue, we don't get that back. So it's not like your fingernails. Your fingernails grow back, not these. Next slide. What do we do for the periodontal examination? Radiographs, we've talked about radiographs in a few places. What do we look for on the radiograph? The level of the crestal bone. So we think about that bone that goes up and down in between the teeth that gives us an indication of health in the mouth. How do we see that? Anybody remember? With a bite wing x-ray. When a patient has periodontal disease, however, we still want the full set of x-rays. We want that for all of our patients for a baseline, but it's essential for periodontal exam. Mobility. All teeth have a little bit of movement, so if you're going to go and take it, oh my gosh, it moves, it should move a little bit. And remember, when you're doing it with your fingers, you feel your fingers moving more than you actually feel your tooth moving. We use a 0 to 3 system to record the degree of movement. 0 is normal, 3 is not. 3 is the worst. The periodontal probing that I talked about earlier, or the pocket depth. So think about a pocket. If you've got one, put your hand in it, okay? So the bottom of the pocket where your fingernails are resting right now, where your fingers rest, this is where your gingiva joins your tooth. So in a pocket, or in a normal place where you keep something, you have a spot where the pocket is closed. This healthy pocket is 3 millimeters deep, and a healthy pocket is called a sulcus. If it is more than 3 millimeters, we call it a pocket. So I use the analogy of the pocket, and I'm going to use it in a couple places as we talk about periodontal treatment. So just sort of wrap yourself around that if your pocket is small, you know, that little cutout pocket that they put on jeans, if your pocket is small, that's a sulcus. If it is deep, or deeper than 3 millimeters in the mouth, it is a true pocket. What happens to true pockets is they collect plaque, they collect bacteria, they become deeper than we can clean at home, and once they become deeper than we can clean at home, the problem becomes that the disease can run unchecked. So greater than 3 millimeters, and my bacteria have a really nice party in the bottom of the pocket. How do we measure these pockets? So we say 3 millimeters or more. How do we measure them? With a periodontal probe. And for each tooth, we measure 6 measurements around the tooth. We go from the distal of a tooth, each tooth, and we go distal buccal, dead center buccal, mesial buccal. And then we do the same to the lingual side. Sometimes on the upper, we call that the palatal side when we're dealing with periodontal examination. But the inside of the tooth, the part that is towards the tongue, we have a distal lingual, we have a straight lingual, right, dead center on the tooth, and we have a mesiolingual. We record these in the chart using red for pockets above 4. Some will also have you circle something that's bleeding on probing. So I want you to take a look at page 365 in your textbook and see if you can tell me what the distofacial probing depth for tooth number 15 is. And so let's go to page 365 here in chapter 20. I feel like that's the wrong page, guys. Sorry. Okay, it's 385. I'm going to switch it right now on this in case you're watching and you don't have your book nearby. And you want to make sure that you're in the right place. Okay, so 385. So that's in chapter 24, which is periodontic chapter. So if I'm looking at the distofacial of tooth number 15, my distofacial probing depth is a 6. So it's 6 millimeter probing depth. That's a deep pocket. It is a pocket for concern, definitely, in periodontics. So you can do that with any of the teeth. So if we want to pick out a real quick one to be sure we understand, let's look at the mesio. Let's do the mesiolingual probing depth of tooth number 18. So the mesiolingual probing depth of tooth number 18 is a 5. So if you got both of those, then you are in a place where you can actually read this. And when I go back on this presentation before I post it, I will put the answers in on the next slide so that you can double check, okay? All right, so instrumentation, we just talked about the periodontal probe. This is how we measure our probing depths. Explorers in periodontics are used to locate calculus, detect the smoothness of the root, and detect the furcation, which is not on the slide, but it is in the textbook. Right? So the furcation is where the root splits. If I can get an explorer to where your root splits, then your furcation is involved in your periodontal disease. That means that the place where the root splits is beginning to hold bacteria. And if you're following the process of disease with bacteria, you don't want bacteria anywhere that you can't remove it. And you can imagine that in the split of the root, just like a trunk of a tree, in the split of the root is not a good place to get bacteria because it's going to stay there and cause problems. So these are periodontal probes and explorers. Those are examination instruments, typically. Our working instruments in periodontal disease for hygiene and for dentists alike, scalers. Scalers have pointed ends, and they are for supragingival calculus. We've got sickles, we've got hoes, we've got chisels, we've got, I don't know, I can't think of the other one at the moment. It's my favorite instrument too. But I know it by its number and not by its description. So these scalers are built to remove calculus above the gum line. And remind yourself what calculus is. It's a collection of calcium and phosphate on the tooth. It's hard. It tends to be yellowish unless it's stained with tobacco or tea or coffee. And it is a great place for bacteria to attach. So remind yourself when we're talking about all of these things, about pockets, about furcations, about detecting the smoothness of the root, that the biggest problem with these surfaces in a disease process is that they are rough and they are going to collect plaque. Curettes are the next type. Curettes have rounded ends as opposed to scalers, which have pointed ends. They are for subgingival calculus. So a scaler with a pointed end can poke into something above the gum. We do not want a pointed end down below the gum because we might poke something we need. So a rounded end is for subgingival calculus. It is used to scrape both the tissue side, or the gingiva, and the tooth side of the pocket. Universal curettes do all tooth surfaces, and these are like 1, 2, 3, 4, 5, 6. Gracies are site-specific. Gracie curettes have one cutting edge, and I think they start, Gracie's might start at 5, 6. I could be wrong about the 1, 2, 3, 4. So the 5, 6, 7, 8, 11, 12, 13, 14. They have 2 numbers because they are doing site specific, and are it's like a mesial and a distal side to the Gracie. What does universal mean? Universal means it can be used everywhere, and these lower numbers are the ones that I can use everywhere. So they've got 2 cutting edges, and Gracie's have 1 cutting edge. Where will you see scalers and curettes? Typically on hygiene setups. You will also see them if your dentist is active in treating periodontal disease non-surgically. And every now and then, if you are a chairside restorative assistant, you will end up having to run and get a scaler or a curette for the dentist. So you've got to be able to identify these as well. And for me, the easiest way to do it is to read the numbers on the side. So before you panic, read the instrument, because you may be able to get a good amount of information there. Some surgical instruments in periodontal surgery, knives, Kirkland knives and Orban knives. Kirkland are kidney-shaped, and Orban is a spear, but the K and the K is how I keep them apart. So Kirkland is kidney. The Orban is for the interdental gingiva. The Kirkland tends to work better on the buccal or the lingual gingiva, depending on where we're at. So interdental, between the teeth, is the Orban. It's a spear shape. We've also had pocket markers. Pocket markers are like drawing a surgical line to follow for a periodontist. One side of a pocket marker goes into the pocket to the depth of the pocket, and then you squeeze it. And what it does is basically puncture the gingiva and leave a bleeding line. So it looks like perforated paper in blood. That may sound a little bit odd, but your patient is anesthetized during this process. This is obviously not done with a tooth that is, or a gingiva that's still feeling, because that would be mean. So this leaves bleeding points that mark the depth of the pockets for surgical guidance. So the doctor has basically a place to cut by knowing where the pocket marker marks. Okay, ultrasonic scalers. You will definitely see these. They are the best thing for saving the wrist of the operator. The ultrasonic scaler takes sound waves and converts it to vibration, and this generates a lot of heat. So we've got a continuous water spray. HVE is the best thing for this because this aerosolizes pathogens. So we think back to our infection control and how we do not want to breathe in aerosolized pathogens. The amount of water spray also tends to wet the mask of anybody close by. So a lot of times an operator will like to wear a face shield while ultrasonic scaling. But remember, you still need a mask on if you're wearing a face shield, because you need to block the inhalation as well as the moisture. It's a separate piece of equipment. It is hooked up to the dental unit. Some of them have their own reservoir for water and they just need an outlet, but others need to be plugged into the dental unit for the water. The tips go into the hand unit of the ultrasonic scaler. So the tips that go in are like our scalers and our Gracies and things like that. So we have these tips that fit only the ultrasonic scaling machine that are shaped like hygiene instruments. They are heat sterilized in between patients. You should heat sterilize these with, if we run a review class, we'll talk about it. But these should be lubricated with emulsion. It's the best way to sterilize those. Not for children, not for pacemakers, or there's a caution with pacemakers. Never been anything, we've never had anything happen where an ultrasonic has disrupted a pacemaker, but it's theoretically possible. So you will sometimes see over the ultrasonic unit in central sterilization, over the ultrasonics that you have for scaling, pacemaker in office, no ultrasonic, and then that there's a chance that this energy could disrupt the pacemaker for the patient, which it could be a life or death situation. Swallowing or breathing problems, like with muscular dystrophy, cystic fibrosis, can be problems with this because of the amount of water. Infectious disease, so someone with someone with tuberculosis, bad idea, because that's an aerosolized disease. We don't want to aerosolize that pathogen. And on the reverse end, someone with compromised immunity may not be able to fight off if there's anything aerosolized in those pathogens, it coming back in. So compromised immunity tends to be those with advanced HIV status, diabetes, things like that. Okay, so non-surgical procedures, what do we do? Prophylaxis, which we talked about in a prior lecture, is the treatment of choice for gingivitis. Scaling and root planing, which is prophylaxis deeper, is for periodontitis. And generally this is done with local anesthesia because it's for pockets and root surfaces. You're going underneath the gingiva. And there is some discomfort with this post-op. Patients tend to be sensitive to cold afterwards. Sometimes there is some recession of the tissues, so they see more of their tooth than they did before. And that tends to be something that patients are not real fond of for this. So they're going to be sore afterwards, and we have some, ibuprofen if they can take it, warm salt water rinsing the day after, things like this. And scaling and root plating is sometimes done with curettage. Curettage is to clean the tissue side of the pocket, to scrape out the tissue side of the pocket. So my pocket analogy again, put your hand in your pocket to feel it. You've got two sides. You've got one side where your palm is and one side where your knuckles are. We've got to clean both of those. So if you think about the bacteria that cause periodontitis as a chocolate bar, a little tiny one, and you put that little tiny Hershey's, let's say a Hershey's Kiss, you put it in your pocket and you walk around all day. Well, now you've got a melted mess. And both sides of the pocket are dirty. So we need to clean both sides of the pocket to get rid of that melted chocolate bar. And bacteria is no different. We've got to scrape the root surface, the tooth surface, and the tissue surface to clean that out well. Tetracycline antibiotic chips and gels are sometimes placed in the pockets to get them to shrink. Tetracycline because it works against bacteria, so an antibiotic kills bacteria. And tetracycline tends to be the one that works best against the bacteria that cause periodontitis. Fluoride can decrease and delay bacterial growth, so is recommended for patients with periodontitis. Sorry about that graphic down there. Maybe if I stop touching it, it'll go away. Chlorhexidine, rinse it twice daily, is best for plaque reduction. Chlorhexidine is a prescription mouth rinse, and it may cause staining for some patients, so they need to be aware that they may notice some brown staining. So think about this for a minute. We live in a society that values the white tooth, and if you have periodontitis, some of the things that we do to treat it and save your teeth are going to discolor them, cause you pain, and generally not be pleasant for either your wallet or your mouth. So periodontal patients tend to need extra support when it comes to encouragement for home care, because that's how they got here in the first place typically. Although there are exceptions to this, there is an amazing table in the textbook that I wanted to point out in this chapter about the things that can predispose us to periodontal disease. So we don't want to overlook those either. So smoking, number one thing that predisposes patients to periodontal disease. You smoke, you have a much greater chance of developing periodontal disease. Some medications predispose this. HIV, diabetes, anything that compromises the immune system predisposes this. Poor dental work or dental work that causes a change in the shape of, and function of the teeth can cause this. I'm sure I'm missing a few things from the table, but those are the ones that are most prominent in my head, the ones that stick out the most. I'm sure that I'm missing one that's probably a real stickler. There is some association between heart disease and periodontal disease, whether that there's still a lot of research that needs to sort of happen there to move that out. And then there are other things that we do with our mouth that can hurry the process along, like bruxing. Bruxing is the continual clenching and grinding of the teeth. So if you're a bruxer, you are at risk for for periodontal disease as well. So quite a few things on those tables there that I think they're separated by a page or two in chapter for periodontal disease. It's really worth looking at because you want to be aware of those factors both for yourself and for your patients so that you can talk about them. So once the tissue is gone, that tends to be, a real bummer. There's no way to get it back. So what do we do? What are the procedures called that are surgical? Gingivectomy, gingivoplasty. The ectomy means to remove completely, and the plasty means to shape. We're going to be using those two words a couple times through the next few chapters. Flap surgery, which is to sort of lift the gum away from the bone and clean out everything underneath it, and then stitch it back together. Gingival graft, we can take a piece from your palate and graft it to anywhere. So if you're missing a piece of gum tissue in some area, we can do that. Osseous surgery, which is either the reshaping of the bone, osteoplasty, or the removal of bone, ostectomy, to make the bony contours better so that cleaning is easier at home. After surgery, periodontal dressings or periopacks are mixed and used as a bandage, basically. They tend to be pinkish in color, although they certainly don't look like gingiva. And we mix them and place them around the raw surgical sites to protect it, because not using your mouth is not an option typically. You've got to get food in, you've got to get nourishment, and you typically have to attempt to communicate if you have the ability. So as a wrap up to the periodontal chapter, careful documentation and patient education is key. Why is this key? It is a very hot legal area. So failure to diagnose periodontal disease is a big malpractice button in dentistry. So if we see it happening in our patients and we don't let them know that they're headed towards tooth loss, and I'm talking dentists, you can certainly do your part as, for the prevention part of this, but the dentist has the legal responsibility to inform the patient about what's going on in their mouth. If we don't do that, then we run the risk of, poor care and leaving ourselves open to lawsuit in the dental office. Okay, so move on to the next chapter, endodontics. Notice the color change, wake us up, right? So endodontics, prevention, diagnosis, treatment of the dental pulp. We're talking root canal here. This is the specialty that is typically feared. It's in culture, it's compared to, the worst thing you can imagine is a root canal. I've had one, they're not that bad. Although I do think every dentist should have to have one before they can do them, because it is certainly eye-opening as to, what exactly the patient does feel and what they don't feel during a root canal. So with management, root canals do not have to be the worst thing. However, fear is not rational. So if a patient comes in and their fear is greater than we can manage, there is always pharmaceutical ways to manage this as well. So in addition to just numbing the tooth or local anesthetic. So what are we talking about with endodontics? It's toothache diagnosis. Now, general dentists do this every single day. They go through a series of steps that help them decide what's causing the toothache. As dental assistants, we are a huge part of this process because we are helping to gather the information from the patient. So what causes a toothache anyways? Typically two things: trauma or physical irritation. Trauma is you got punched in the jaw or in an accident that involves the jaw, or caries, which is our physical irritation. The bacteria are a physical irritant. Chemicals that we use, such as acids in dental materials, acids in the food that we eat and drink, or whitening materials, are all chemicals that can irritate a tooth and cause a toothache. Those are the two main reasons for pulpal pain, for toothache. What are the symptoms of a toothache? Pain when closing or chewing, hot and cold sensitivity, facial swelling. So we need to ask our patients, are you feeling this? Does this feel that way? This is the subjective part of the exam. So it's the part that our patient tells us. What do you feel? What are your symptoms here? How long do they last? How severe are they? Where are they? You would be surprised at how many people, when they have a toothache, cannot actually tell you where it is. So it sounds like it's an easy thing. Well, I have a toothache, fix it. But it isn't always so simple. The objective part of the diagnosis is what the dentist collects for information. So I can tell you I'm in pain, but you can't prove that, right? That's the subjective. The objective are all the pieces of medical information that I can gather, dental information that I can gather. So our history, radiographs, and then clinical exam. Clinical exam for pulpal diagnosis includes percussion, palpation, and hot and cold tests. Percussion is to tap on the tooth. So tooth tapping should give a certain response. So when I tap on the tooth with the butt end of my mirror, the dull end of my mirror, it shouldn't stick you to the ceiling. And if it does, I may have found my tooth. I may have found my problem. So what we do when we're doing our clinical exams is we have a control tooth, or a tooth that we expect and the patient can tell us feels normal to them. So the normal tooth is the control tooth, and then the suspect tooth is the one we're trying to identify. So if I tap on and the control tooth is healthy tooth of the same type in the opposite quadrant, the book gives a few examples and asks you to prove that you can do this, and I'm going to ask you to too. So if I come in and I tell you I have a toothache on my molar up here, my first molar, this is my upper right. So this first molar up here, tooth number is 3. And the control tooth would be the same tooth on the other side of the mouth. And so that would be this same tooth on the left side on the upper, which is number 14. So the dentist may take and tap on the control and then tap on the tooth that I say is bothering me. And I can make, gathers diagnostic information from that. Palpation, I'm going to touch the gum with my fingers and, push on the tooth to see if this tooth responds any differently than my control tooth does. I'm going to do hot and cold tests on both teeth to see if I get different responses. Pulp vitality testing is probably one of the things that sounds the most barbaric but can give a lot of information. So a pulp vitality tester is a small handheld electric shock device. So I used to joke with my patients, okay, we're going to shock your tooth now and see what happens. But obviously that isn't the way you explain it to a patient who's never had it done or, that you don't have a good relationship with. So what is pulp vitality testing? We pass a low current through the tooth to see if it responds. This tells me whether your pulp is alive or not. There are different degrees of reading on pulp vitality testers. Not all docs agree on this, but in general, if you get a response from a tooth, it's still alive. If you don't, it's not alive. Response meaning the patient says, yep, I can feel that. So we don't shock the tooth to see If we can get you to stick to the ceiling, we shock the tooth or pass the current through the tooth to see where you begin to feel a slow, sort of warm sensation saying, oh yes, I can feel something there. That's what this does. There is a procedure on how to assist this in the textbook. This is, we need a conductive substance, usually toothpaste, and a ground wire, because you've got to ground your patient if you're going to give them electricity, no matter how much it is. Okay. In some states, that's an expanded function, too, so you can do it yourself. All right. What are the conclusions after we gather all our objective and subjective information? We have reversible pulpitis or irreversible pulpitis. And I want you to kind of think about, when we were talking about periodontics, we talked about things that were reversible and things that were not reversible. So this is a theme for many of the things that we try and diagnose with teeth. And so reversible pulpitis, your pulp is inflamed. It responds when we poke it, but it likely is not going to die, or at least not today. What's the treatment for this? A sedative filling with IRM ZOE and pulp capping, which we're going to get into in a moment. If you have irreversible pulpitis, your tooth is infected and it doesn't respond. Or it responds so much but does not go away. And the treatment for this is either root canal or extraction. So this is why we're here in this chapter, is because we want to save as many teeth as we can from extraction where it's practical. So here's a graphic showing what I'm talking about with reversible and irreversible. Now the one on the left side is the better of the two for deciding between. So in one, on the black here, and if I point to it, on one side of this I've got the inflamed pulp tissue, and you will notice that there's still a bridge of dentin between the pulp and this decay, the infection. On the other side, with the infected pulp tissue, the decay has gotten deep enough that it has infected the pulp. And once that happens over time, we end up with an abscess here at the apex of the tooth. Abscess is a collection of pus. What makes this so painful is that it's trapped in the bone and there's nowhere for it to go. So you can have a collection of pus on your hand, you can have a blister, something like that, or a small infection, and it's not going to cause you the kind of discomfort that it will cause you in your mouth. And this is because the bone is just trapping that there, and the pressure makes our nerves throb and ache. So I like this graphic because it's very illustrative of what happens as decay gets deeper and why we don't want to neglect decay in our mouths. And then this one is just a graphic of a fully infected tooth. So does the abscess have to be on this side? No, it doesn't. It can be on this side too. No telling what the body will do to fight off the infection. So with the inflamed pulp and the reversible, we say that we want to put a sedative filling in. We need a filling that's going to tell the tooth, shh, it's okay, it's all right. And we usually do that for about 2 to 4 weeks. When the tooth has completely calmed down, then we may put a permanent filling in. Sometimes we go right to the permanent filling too. This is a decision that the dentist will make based on different parts of diagnosis. But we have 2 things that we do endodontically, 2 procedures in endodontics that deal with this reversible pulpitis or the inflamed tooth. One is the indirect pulp cap and the other is direct pulp cap. And the names are very descriptive. So either it's near it or it is on it. And when it's on it, root canal is coming, probably sooner rather than later. When it's near it, maybe not. Maybe go the whole life of the tooth without having to move to the next stage of endodontic treatment, which is root canal. All right, so let's talk about the radiographs that we use in endodontics. The initial diagnostic periapical radiograph should show 4 to 5 millimeters beyond the apex. And it shouldn't be distorted. That's a really big deal. It's got to be true to life. So then if we've progressed to root canal treatment, we've got working length, which is taken with the file in the tooth. We've got the final instruments and completement radiograph after temporary and final fill. And I'm going to show you these different stages. So what do we do for a root canal? First, we start with anesthesia and pain control. The local anesthetic, and remember your colors. Remember the sky is blue and the sand is yellow. And we may have to inject directly into the pulp, which is never a fun situation for the patient, the dentist, the assistant. That is painful. But sometimes it's the only way to get an infected, unhappy tooth to be quiet. Once the pulp has been removed from the tooth, we may not need to use anesthesia at all. That will be the dentist's decision generally. But a patient may not need it at all. Okay. Sorry about that. All right. The next step after anesthesia is isolating. So the rubber dam is the standard of care. Standard of care is a legal term. It means if you don't do it, I can sue you. So standard of care for endodontics is rubber dam. So it has to be on your setup every time you set up for it. To review the setup for rubber dam, we've got the frame, and for endodontics, plastic is best because x-rays will pass through the plastic. They will not pass through the metal. So you have to take this frame off if you're using a metal one when you are working in endodontics. We've got the clamp, which holds the anchors the dam to the tooth, and you can see a really nice version of it here. This is a canine, and this is an example of an anterior clamp and how well that isolates the one tooth that we're performing the root canal on outside of, the whole mouth. This is a rubber dam napkin here that helps to control saliva and irritation of the dam rubbing against a patient's face. This is another way to stabilize a dam in the anterior of the mouth, and that is with these little things called wedgets. So no clamp, just little plastic or latex strips to help to separate that. So that's one way of doing it. Sorry for the ums. If you look at, I'm going to try harder. If you look at these teeth here, you can see they have been entered for root canal. So we're going to talk about access next. This is endodontic access. This is how we get in to that pulp chamber. These are anterior teeth. This is what they look like from the front. This is what they look like from the back. So you're looking in a mirror right here. So your view is actually straight at the teeth, and then there's the mirror showing you the back. Sometimes it's difficult to orient yourself in oral photos. Once we have this placed, we're going to disinfect with iodine, which I haven't seen done very often. Sodium hypochlorite is what I've seen disinfection done with. Disinfect, by that I mean the area around the tooth and on the dam is rinsed or swabbed with something that will kill bacteria. Sodium hypochlorite is bleach. Do not ever say bleach to your dentist with the patient in earshot. So you say sodium hypochlorite. If I say bleach with a patient in earshot, what do they think? They panic. You can't use bleach on me. Sodium hypochlorite is diluted with water for this. The dilution of sodium hypochlorite and water is like swimming in a pool. And no one would complain about that, or very few would complain about swimming in a pool. But if you tell them it's bleach, the freak out begins. So I'm not asking them to swallow it, and I'm suctioning all of it up if I'm a good dental assistant. But I still don't want to say anything but sodium hypochlorite in earshot of my patient. I want you to notice here in this photo that there's a file sticking out of the tooth, and we're going to go over what those are. So for access, the pulp chamber is entered, nerve canals are located. How do we do this? High-speed handpiece, round burr, an Endo Explorer, which there's a photo of up here at the top. I can scoop out the pulp tissue with an endodontic spoon. And then inside the roots of the tooth, which this is a gorgeous picture right here of what it looks like with, these are the nerve openings inside the tooth. So I want you to stop and think just for a second about how big are these right here. They are small. Endodontists and general dentists who do root canals work in millimeters, and they work in dark and really difficult to see places. This can make the process, a lot of it's done by feel and by radiograph. Things have improved with technology, so I've got some other things that help me out now. I'm going to talk about those in a minute or so. So to remove the pulp tissue from inside of these canals, I use a barbed brooch. It's basically a fish hook on a tiny, tiny scale, and there are a bunch of them. So this goes in all the way to the tip of the root of the tooth and pulls the nerve out with it right here. So what does a nerve look like? You're looking at it. Isn't it pretty? I thought you might like it. One of my favorite things to do would be to remove a nerve hole from the inside of the tooth and put it on the bracket table, which is where the instruments are kept chairside, and freak out my dental assistants with it because they do move a little bit after you remove them. The nerve tissue contracts and expands. It's fun. So if you ever get the chance to see it. All right, so once I have accessed and removed the nerve tissue, I want to debride and shape. And I do this with Gates Glidden drills. If you're a Nemo fan, go back and watch the beginning of that movie. They talk about Gator Glidden drills, so you'll realize all of a sudden what they're doing there. And Gates Gliddens shape the canal. They help us to get our instruments to the very bottom of it. Files, most of the time, although we still use hand files all the time, will be mounted on a handpiece now too. And this is for better control and better cleaning and shaping of the inside of the tooth. These are numbered by size and color-coded. And you can see 15, 20, 25, 30, 35, 40, the color codes. Those are all repeated here. And there are different shapes of files. So there are K files, there are Hedstrom files, and there are triangular shaped files as well. Those are reamers for different aspects of cleaning this out. So if you work for an endodontist or for a general dentist who does a lot of endo, you're going to get really familiar with these. And these have only so many times that they can be sterilized before they need to be thrown away. And if they are thrown away, where do they go? They go in sharps because they're pokey. All right. So some endodontic offices have ways of keeping track how many times these have been sterilized, so that this, you've got a system. If they are sterilized too many times, they can break down in the patient's canals. Breaking a file in a patient's canal is a lousy experience. There are some ways to remove them, but a lot of times the file has to be left there and the patient has to be advised that their root canal could fail at some point. And that's never a great thing, especially if they're paying a lot of money, which root canals are not cheap. About $1,500 to have a molar saved with a root canal, so not cheap. But there's a lot of work that goes into it and a lot of education behind it. And if you think about saving other parts of your body, I'd say it's a relatively cheap surgery. So this endodontic file is sticking out of the tooth here. And that is what I'm going to take an x-ray of right there, is the file inside of the tooth. And I may even have more than one in there to determine how long that file needs to be to clean out the whole canal. And we call that working length. So I don't want to clean out half the inside of the tooth. That won't get rid of my infection. I need to clean out all of it. And in order to be sure that I'm cleaning out all of it, I use radiographs to check this. The other thing that we use to check the length of this is called an apex locator. An apex locator is a fish finder for the apex. Bear with me here. So a fish finder is something that you put on a boat so that you can decide where the fish are in the lake, and it beeps when you get to where the fish are, lets you know. An apex locator is attached to the file, and when the file gets to the bottom of the canal, it beeps. So technology has allowed us to sort of get a lot better at root canals, and that gets us a more predictable outcome. Working length is key to root canal success. Here is my sodium hypochlorite in its syringe that I'm going to use to irrigate the inside of the canals. Irrigation flushes out all the debris, all the inside of the tooth that I'm cleaning out, and suction is used while this goes on. And I can also dry it off with some absorbent paper points. So once I have cleaned and shaped my canal and irrigated it to kill any remaining bacteria and flush out debris, then I'm going to dry out the inside of the tooth because I want a nice dry surface to work with for my next step, which is obturation. Obturation is a fancy way to say filling, but it's used to say filling in endodontics. So we use gutta percha, which is a rubber that is grown on a tree. I want to say in South America is the most common place for it. I knew someone, I think they do maybe grow it in India too, but I knew someone who had a gutta percha farm. It's kind of neat. They make super balls out of gutta percha. Gutta percha is rubber. So what is special about gutta percha for the tooth? Gutta percha is inert to the body, which means the body doesn't want to try and eat it up or call it foreign and cause a reaction to it. So we use gutta percha, and it's warmed, and that fills in the canal spaces that I just cleaned up and dried out. How do I do this? I do this with a plugger, which squishes it down, and a spreader, which allows me to layer it in there. So if you think about a tube of frosting, if you've got a clump of frosting in the top, you've got to squeeze that frosting down to get it all the way to the tip. And this is what we're doing with warm gutta percha, is we're heating it and moving it so that it will get all the way down to the end of the root, so that it will fill in this area here. See how pretty? So this thing that looks like some kind of rocket ship, or I don't know what it looks like, is the modern way to obturate a canal. So these come with heated cartridges of gutta percha that I can actually inject in, and there is a system and a way to do this. So if you have met one of these in your practice, your biggest concern is what as a dental assistant? Infection control. So you need to make sure that there's a new tip on here for each patient, and that according to manufacturer instructions, you are disinfecting these appropriately or autoclaving them as possible. So some of these have detachable tips that autoclave too. So those are the main concerns as the dental assistant, that and knowing what to pass and when. So Doc is going to ask for a certain size of gutta percha, and he may ask you to measure the gutta percha. He will ask you to transfer the plugger and the spreader to, these are spreaders here, and that's a plugger there. To him, he may heat the plugger to help remove some of this rubber from the inside of the tooth, some of this gutta percha. One thing I noticed about the chapter is that it didn't go into the measuring a lot. The procedures did, but the chapter didn't. Measuring of the length of the file, we've talked about that with working length, but a lot of time that falls to the dental assistant to keep those measurements of the files. So the file has a rubber stopper on it, and the stopper is your measuring meter. So you're going to place this file against a ruler, and usually it has a cutout for the stop, and you're going to push the file to the correct millimeter measurement. And you want to double check this before transferring it. Your doc will likely double check it too, but the more eyes on this, the better, because working length is so critical. So that's my little story on measuring. So what does it look like when it is completely filled inside? It looks like this in the inside. So I'm going to go quickly back to the beginning. It looked like this. We've got some blood and we've got a nerve that needs to be removed. When I'm finished, I've got these wide open spaces that have been nicely filled with this pink gutta percha. And that is what saves a tooth from extraction. That is a root canal. What does it look like on x-ray? It looks like this. So this is a gorgeous example of a nice root canal that has had a temporary filling placed and likely some cotton right here in the middle. So once the gutta percha is complete down in the root canal spaces, we will place some cotton to block the irritants, and then Cavit, which is a temporary restoration material that is placed with a Glick or a Woodson. That is the instrument that has a paddle on one end and a condenser on the other. So I'm going to put some on my paddle, transfer it to the dentist, and he can use the paddle to place it and the condenser to squish it in. Final restoration is done at the general dentist. If you're doing all of this at the general dentist, some of these steps may be combined. When we get to when we talked about prosthodontics, we talked about the fact that we might take this and put a little rod down into it or a post to make it keep the tooth nice and solid so that it doesn't fracture. So what is the final restoration for an endodontically treated tooth? It's going to be a post that goes down into one of these canals, the more straighter one usually, so maybe this one. And it almost looks like there might be one there, but I don't think so. I think that's just gutta percha. But we're going to put a post down in there and then a crown on top of this. So we want to remember our prosthodontics. We're looking at that. Okay. So the first line of therapy in endodontics is pulpal regeneration, which is pulp capping. Root canal therapy may then be indicated to save the tooth, which otherwise could be headed for extraction. Okay, new color, new subject. Wake up again. Oral and maxillofacial surgery is next. Unless you are working for an oral and maxillofacial surgeon, you're not going to see a lot of surgical procedures in a general office. What you will see are single tooth extractions. You may see even some dentists who will do more than one extraction in preparation for placing a denture. So what do we do with the oral and maxillofacial surgeon? Well, I can read the book definition to you. Hard and soft injuries of the head and neck, diagnosis, surgical disease, treatment, trauma, cancer, and extractions are the typical run of the oral and maxillofacial surgeon. Impacted teeth and teeth that are harder to get out, typically, at the oral and maxillofacial surgeon. The general dentist, simple extractions, or single tooth, rather. Simple, I can do many of them, but single tooth mostly. So a general dentist will likely refer all but the simplest extraction cases to the oral and maxillofacial surgeon. Where does it happen? Hospital, OR, specialty office, general office. You've got to have the supplies to back this up, however. So if you're doing surgery in a specialty office or a general office, you've got to have all of the drugs to maintain life and medical emergencies on hand. You've got to have facilities for anesthesia, all those things. Informed consent by the patient. Remember, all the instruments are critical instruments, so we heat sterilize them. Who are oral surgeons? They've got 4 to 6 years of schooling beyond dental school. So if you look at that, that's 8 years beyond high school, plus another 4 to 6. All right, so that's good schooling. These guys and women are sharp. They are MDs. Some of them carry dual degrees. Most always they have hospital privileges, which means they're on staff as oral surgeons for consulting in emergency rooms and things like that. You have got to you have to maintain asepsis when you're doing oral surgery from setup to cleanup, which means the absence of microbes. There's a surgical scrub technique and gloving technique in the procedures. You should read through those. If you are in a general office, you will likely not do them. Those are saved mostly for the OR and for specialty office scrub-ins. Recall from our infection control unit that surgical gloves are sterile. They are right and left-handed gloves. They don't come in a box. They are separately packaged, and they have a cuff. So they're a little different than the ones that we use for everyday treatment or examination gloves in general offices. When we talk about asepsis in general offices, this you should still do your best to practice. So when you open your instruments, you allow them to fall onto a clean surface. If you are in an oral surgery office, you will likely even have the sterile inside of the package to go ahead and do your instrument setup. So you don't get to play with your hair while you're gloved. You don't get to rub your face while you're gloved. All of those break asepsis. So that's a procedure that takes some good concentration there. Okay, talk about extractions. Forceps extraction are often called routine or simple. This does not imply that they are non-surgical. What it means is that that they usually don't require sutures. It is still surgery, however. So the removal of a tooth is always surgery, even when it is routine or simple. Local anesthetic is typically sufficient for this, and we use elevators to luxate the tooth, so make it wiggle, and then forceps to grab the tooth and remove it from the socket. The socket is then compressed, and the patient bites down on gauze for 30 minutes, not all of it in the office. Most of the time they do that while they're traveling to home. And that's about it. There are some post-op instructions we're going to talk about, but a routine or simple extraction is just that. Not a lot to it, unless, of course, you're the patient. Multiple extractions is simple extractions repeated until all the desired teeth have been removed. Multiple extractions typically come with alveoplasty. Alveoplasty is to change the shape of the bony ridge that's left behind once the tooth has been extracted. So if you think about having a tooth out, there's all this bone left over that doesn't have a function anymore, and it may have some sharp edges to it. So the dentist is going to use a file or a surgical handpiece to smooth the bone, and then they will remove the sharp edges of the socket with a ronger. A ronger is like a fingernail clipper for alveolar bone. I think I have one. Maybe I don't. But I'll show you something that is similar to. If I've got it with me, I may have it with me. And then sutures will be placed in this case in most of the time because there are many open sockets there, and it becomes harder to keep things out if you don't keep the tissue closer together. It's not always necessary though, so it's surgeon preference there. The next thing is the complex extraction or impaction. A complex extraction, as opposed to a simple, is when the crown of the tooth is not visible or is likely to break when we grab it. So healthy teeth are not extracted typically. That's the whole point of this. So is it likely that the crown of the tooth will break? Yes, it is. And that's when it's a complex extraction, if it pops off. This is why a tooth that may look simple is referred to a surgeon, because once that crown is broken off, it becomes complex, and then that's harder for general dentists to attack. So what do we do usually with an impaction, say a third molar or a complex extraction? We're going to use a scalpel to open the tissue, to expose the tooth roots. We may use a chisel and mallet to section the tooth in half, or a surgical handpiece to put it into pieces. The elevator and forceps is then used, luxate, crab, and then sutures are placed. So there are extra steps here in the scalpel. Typically, the rule of thumb is if you've got a scalpel on your setup, you better have sutures on your setup. And that is a way to look at it. Let's talk about sutures for a minute. Silk, poly, nylon, if you can wear it, the body doesn't resorb it. And the patient has to come back 5 to 7 days after surgery to have them removed. Gut, chromic, and Vicryl, which I've never worn before, how about you, are absorbable and the body will take care of them. That doesn't mean I don't want to see my patient in 5 days. It just means I don't have to remove the sutures. Suture needles are said to be 3/0 or 4/0, and it's written as 3-0, but we say 4/0. So if I say I want 4/0 gut that I am looking for, a package that says gut on it, and 4-0. What is gut? It may say cat gut. I promise you, for all you cat lovers out there, it's not cat gut. It's actually sheep gut. I don't know why it's called cat gut. I think it came from cattle instead of saying, so it was like, anyways, who cares? Point is, it's not cat gut. Don't freak out. So expanded function for the dental assistant to remove sutures. And how do you do that? There's a procedure in there, but to sum it up, you grasp the suture at the knot with a cotton plier and then snip it and pull it through. So as long as you're holding the knot, the pain to the patient is lessened in that case. We do not use anesthetic to remove sutures. So it sounds barbaric, but it's not necessary. The anesthetic is worse than the suture removal. So as long as you hold the knot, the thin part of the suture will pull right through the tissue. And that's that. Okay, post-op management. What do we tell our patients? Bleeding is normal. Call if it doesn't stop. So I tell the patients usually they're going to ooze for a little bit. But if they are bleeding more than is normal, or they feel that it is not stopping, then they need to make a phone call to the office. No rinsing and spitting for 24 hours. Restrict activity. Anything that gets the blood pressure up, like running or working out, is not good for a fresh surgical site. Pressure with the gauze pack for 30 minutes and don't disturb the site after the gauze pack is removed. We typically give patients extra sterile gauze to take with them because it may get too soggy before 30 minutes, but you got to be real clear. So don't give them, 40 things of gauze and not tell them about the 30 minutes, because if they go beyond 30 minutes with the pressure, they could end up pulling the clot out when they pull the gauze out, and that results in dry socket, which is at the bottom of this slide. So swelling, ice on and off for 20 minutes on the first day, heat on the second day if indicated, if you want it. So no heat on the first day. Ibuprofen, warm salt water rinses after 24 hours. So no swishing and spitting for the first 24 hours, but the warm salt water keeps the area clean and is actually soothing after 24. Why 24? Because we want that clot to happen. If the socket fails to clot, a dry socket is the result. The real name for dry socket is alveolitis, and this typically happens 2 to 4 days post-operatively, and it is one of the most painful things to go through. It's basically an open bone wound. And so there is a great deal of pain with this. It can be treated with some gauze packing that has iodoform on it. That the iodoform is a disinfectant as well as a anesthetic, and the gauze needs to be changed usually once every day. So you're going to make good friends with your alveolitis patients or your dry socket patients. So be sympathetic and be professional with them. Sometimes they tend to be stuffed into our schedule at places that isn't appropriate. They tend to want to blame the dentist for the dry socket, even though it's a failure to clot. So as the dental assistant, help to educate the patient about the fact that sometimes that failure to clot is not anyone's fault but the body's. However, smoking, rinsing too soon, can hasten or cause alveolitis. But some people just get it, and they didn't smoke and they didn't rinse, they did everything right. So what betrayed them? Their body, not the dentist, not you, not, all the things that patients want to blame for those types of things, because pain makes you grouchy. So the dental assistant plays a key role in oral surgery. If you love this stuff, surgical assisting is a very satisfying career. And many people go on to do that. My sister-in-law did it for 5 years, and she's a CDA. She loved it. So if surgery's for you, that's a good place to be. Okay, color change again. Wake up, pediatric dentistry. So we are almost to the end of our chapters. Pediatric dentistry is for children, but also special needs patients. So you may still see patients who are, say, in their 30s in a pediatric office if those patients in their 30s have special needs. Special needs, Down syndrome, cerebral palsy, things that cause mental and physical challenges for the patients. For patients without special needs, adolescence is typically the cutoff, 18-ish. All right, so, and then we ask them to find a general dentist. So pediatric care is done in themed room. So you might have a fish theme, the inside might look like an aquarium, there's TVs on the ceiling. It is kid-focused, video games. There are quiet rooms usually in pediatric practices that are glassed off, so you can see in, but you can't hear, and that's where the screamers go. And I say that to get your understanding. Why do we treat the rest of the kids in open bays? Because psychologically, if you see someone next to you behaving, you are much more likely to behave. And so if we've got a room full of children who are behaving, we're a happy pediatric practice. The ones who have challenges with behaving possibly are sedated or are likely to cry more than normal will be done in the quiet room. Remember that the parent always must give consent for anyone under 18, so even teenagers need consent. Sorry, guys. Pediatric orthodontics. What do we do in pediatric practices? Not anything that different than we do in regular practices, but I will bring up orthodontics in a small measure here. Preventive for pediatric practices, thumb-sucking appliances, space-maintaining appliances, holding a seat for that permanent tooth that we expect to come in a year or so is preventive. The interceptive are things like palatal expanders. Those are the little things on the roof of the mouth that can be turned with a key to sort of correct an undersized maxilla or an upper jaw that's too little. Crossbite appliances, there's a picture of that in the textbook. A crossbite is basically when your lower teeth are, so if you bite down, your upper teeth are on the outside. They're the outside of the fence. If you have, say, 3 teeth on one side or even 1 tooth on one side that is on the outside of the fence and shouldn't be, we're going to bring it back in with a crossbite appliance. Other procedures in pediatric practice, sports safety is a big deal, so mouth guards, best way to prevent injuries to the mouth during sports. Restorative is the same as restorative in larger offices, except with smaller hand pieces. And we mentioned the T-band, which is a belt-like matrix band that is used for children. It does not have a retainer. Some don't use this anymore. Some just use the universal retainer and a pedo-sized band. So all dentist preference. Pulp therapy is a big deal with primary teeth. Pulpotomy, and this was mentioned in the endo chapter, but I saved it for here because it is, pulp therapy in primary teeth is different than in permanent teeth. A young permanent tooth is going to get a calcium hydroxide pulpotomy. What that means is we are going to remove just the part of the pulp that is in the chamber of the tooth, not down in the root, and replace it with calcium hydroxide, which is something that stimulates the growth of dentin. And we know that that patient's going to need a root canal later, but this is a stopgap measure until we get there. For primary teeth, pulpotomy with formocreasol is performed. Formocreasol is a chemical that kills nerves. And we do this for primary teeth because we know that they are going to wiggle and fall out, and the permanent tooth will come in at a later time. So 2 different therapies, 2 different materials. They're both called the same. They're both called pulpotomy, which is to remove only a piece of that pulp, but they're done with different materials. Trauma is a common thing in a pediatric practice. The most common are 1 to 2 years of age maxillary centrals. This is because munchkins are learning to walk then. Discolor, may abscess, may need extraction before that permanent tooth comes in, which is then where we think about space maintaining. If a permanent incisor has trauma, if it's fractured, we do the calcium hydroxide pulpotomy or pulp capping, and it's likely still going to need a root canal. If a permanent incisor is avulsed, which means that it pops right out of the socket and you've got to pick it up off the ground. This happens in baseball. You get hit right at the right point in the socket and that'll pop right out. So the avulsed tooth can be reimplanted in 30 minutes. And it will still need a root canal later, but we run the chance of saving this tooth. So only permanent teeth that are avulsed are reimplanted, and it's going to be done within 30 minutes for the best result. Why are baby teeth not reimplanted? It doesn't work as well, and we know that there's a permanent behind there. We don't want to damage that one. Okay, so for pediatrics, what's the most important thing? Developing rapport with your patient, which means having an understanding of children. So on the second page of the chapter, there's a list of different stages that children go through and what to expect at a certain age. So until a patient is still a child, is about 9 years old, they are not, they still hold on to their fears, and they're not quite as socialized. After 9, socialization, letting go of fears, understanding the world around you, that's when that comes in. So know your kids. If you're if you're a brave soul and you're moving to pediatrics and somebody's going to do it, more power to those of you who can. It takes all kinds to make this world go round, right? Okay, so our last chapter is orthodontics. As a general dentist, I'm typically allergic to orthodontics, and that's a joke. It just never really bit me. I didn't love it. I don't hate it, but as a dental assistant, orthodontics allows a great deal of patient care if you're a dental assistant. So you may find that this is something that calls you, especially a lot of people who have had braces are called by orthodontics because you had such a great experience and you want to be able to do that too. So what happens when someone has a bad bite or malocclusion? Psychosocial problems can happen, which means kids tease you and it changes the inside of you as you develop. So if you've got buck teeth and you've been teased about those for most of your formative years, you are not a happy person. So that's a psychosocial issue. Patients who make it into job age with malocclusions are sometimes more difficult to hire because of the aesthetic that we expect in our employees these days. Functional problems can happen, which means that a malocclusion prevents you from chewing properly, or there are things you can't eat because you can't chew them. And then eventually disease processes result. So what comes after all of these things, you may end up losing your teeth because they are not connected in the way that is healthy. So malocclusion, can result in all these things. So who fixes malocclusions? Orthodontists. What is a malocclusion? It's classified by a guy named Angle, so we call them Angle's classifications. The mesiobuccal cusp of the maxillary first molar is the key to classifying occlusion. So if you find your maxillary mesiobuccal cusp of your first molar, it's up here. I don't have my large model. Oh, yes, I do have my large model with me. Hold on a minute. And I'm just going to make a little mark. There's one here, but I'm going to make it a little brighter. Okay. All right. So here is okay. So you can see if you look. I've made a little mark on the mesiobuccal cusp of the maxillary molar. And if you find your own, as I just said a moment ago, find your own, the only way you can move that mesiobuccal cusp of the maxillary first molar is to shake your head. So go ahead, try it. I'm kidding. But you cannot move your upper teeth. You can only move your lower teeth. So I can move the lowers, but I can't move the uppers, which is why this tooth is perfect for being the key to occlusion, because it's a fixed point on the skull. All right, so here's my purple mark. All right, so class 1 is like this. Let's see if I can get you a closer view. Look at that. All right, so class 1 is like that. The mesiobuccal cusp of the maxillary first molar is in the buccal groove of the mandibular first molar, which has a little pink dot on it. See that dot right there? All right. If I am class 2, that mesiobuccal cusp moves mesial to the buccal groove. You see that? It moved towards the front. If I am class 3, that mesiobuccal cusp moves distal to. Let me show you what happens in class 3. The patient looks like the bulldog. Okay? They've got their lower teeth. In front of the uppers. That's not a good place to have them. All right? Now, if I'm class 2, and my mesiobuccal cusp is in front of, or mesial to, the buccal groove on the mandibular molar, then I'm bucky. So I end up like this with buck teeth. If you're me, you can have both. You can be buck teeth and have a nice deep overbite. That's division 2. All right. Isn't that nice? So while we say that, yeah, I know. The hairdresser did me awful with my hair, true story. If we say that that functional issues, disease processes are caused by a malocclusion, and then you look at my teeth and you think, okay, so she's ancient and she's still got her teeth. Yes, that's true. So does it happen all the time? No. Is it possible? Yes. Do I have areas that do not do what I want them to do because of my malocclusion? Yes. I just never had braces when I was a kid, and then as an adult, I was stubborn. I didn't want to. And then there becomes a point when you don't want to pay for it either. All right, so that's just something to sort of think about, that I have to work extra hard to maintain those because of a malocclusion. And I'm not average because of what I know and because I've been in the business so long. So that happens, is that you can't always, predict exactly what. Okay, all right, we're almost there. In an orthodontics office records treatment planning, the big thing are the 5 photographs that we take. We take the profile, which is from the side. We take the frontal view, which is this way. We take a view of the right buccal, which shows me the angles classification on photo. We take a view of the maxillary occlusal, so you get a picture of the palate and all the structures. And then we will take all teeth and occlusion, like this. All right. So we take photographs that go into the patient's record. We are taking a radiograph, which is usually cephalometric. So if you go back to your chapter on radiographs, that is a profile picture, an x-ray and profile, and it shows me soft tissue and points on the patient's skull so that I know how long to move, or how long the patient needs to be in orthodontics to move the teeth. Some orthodontists use panoramics. It all depends on the doc. Most use a Ceph. Diagnostic casts, which we saw way back in the very first lecture. The nice patient presentation models and the white orthodontic plaster. And the other thing is the medical history, the dental history. Motivation for patient treatment. So most kids are there because their parents send them, but they've got to be cooperative. They've got to be motivated to do it, or orthodontics isn't going to work. And also physical growth and maturation. So it's not abnormal to have to ask a parent about puberty in a child. And that can put the parent off because they may not understand why you're asking. So why are we asking about that? Because we want to know where the patient is basically in their growth cycle. And okay. So there are, the textbook mentions interceptive orthodontics. It mentions limited orthodontics. I'm keeping this presentation focused to comprehensive orthodontics because that is by far the more common. So for what is comprehensive, it's fixed and removable. It's braces, which is familiar to most of us. Whether we've had them or not, you see people with them, they are common. Removable are the retainers that tip teeth, maybe one tooth, or maintain the treatment after the fixed have been removed. Okay. So the overview of the fixed appliance. Separators are applied to make room for bands. Elastic or stainless steel springs are placed between the molars and the other teeth to make room for the bands. The bands, and that's usually about 5 days before treatment, a week before treatment. The bands are cemented with glass ionomer to first and second molars after the separators are removed. Bands have cleats, tubes, buttons that attach to power products, and we're going to talk about those in a second. Brackets are bonded to all the other teeth. So I've got bands on my molars and brackets everywhere else. And a bracket is bonded, a band is cemented. Excuse me. So brackets are bonded with etch and bonding agent and composite. And then arch wire is ligated to the bracket with elastics or metal. believe the next slide has the power products on it. Yeah. So arch wires, elastics, elastic chains, Kobayashi chains, ties and hooks, headgear. These are all things that expand or are elastic and then we'll go back to once they have been expanded. And they are used to move teeth. So what is elastic? On elastic, you fling it across the room. So I stretch it out, but as soon as I let it go, it comes back to what it was. So what we do with arch wires is we use them as the template for what we want the jaw to look like. So an arch wire is the perfect. And when I place an arch wire and I ligate it to those brackets and then anchor it on the bands that are on the molars, the teeth have to move to keep up with that arch wire that wants to go back to the perfect shape it was. Elastics do the same. Elastic chains do the same. Kobayashi hooks do the same. Headgear does the same. Everything we use, or these power products, are used to be the ideal, and the body is expected to move as that wants to go back to its ideal. So removing teeth. And headgear typically directs the growth of the bones as they go. So headgear tends to be used when growth is still happening. Diet or when you really need to move something. So a severe case may end up with headgear to help pull those molars to where they're supposed to be. During and after treatment, diet and hygiene greatly affect the outcome of the orthodontic process. So hard stuff, sticky stuff, those are all out once you end up in your braces or your fixed appliance, your fixed orthodontic appliance. Hygiene is super important. Number one, because your gums are not going to be happy with you if you neglect them at all. But especially when you've got something that allows plaque to stick to it all day, which are these metal wonders in your mouth. Hygiene is also important because if you let plaque build up around the bracket wires, it can leave white lines on your teeth once they're removed. Sucks the calcium right out of the tooth and leaves a white line behind. Not a good thing if you've got this gorgeous smile and then these white stripes, right? Once a patient is finished with treatment, we put them in a positioner, which is a soft, removable, has the upper and the lower in it and just holds everything happy. And then a retainer, which holds our treatment results. Your teeth tend to want to go back to where they were. So I suppose just like an arch wire is elastic, so is our jaw. It wants to be where it was. And the retainer helps to hold those results in place. And so a patient should wear their retainer if they want to maintain their orthodontic treatment, if they want that to stay put. Orthodontic dental assistants, as I said before, you've got a great role in direct patient care. You can have a great influence on a lifetime of oral health for your patients if you're motivated in that direction. Okay. Okay. So that is the last few chapters. And being that this is our last class, I want to remind everyone, what do I do? What do I need to do to be complete? How to be sure that you're going to receive your certificate. So watch all 10 lectures. Email the school before you're watching if you're not attending the live webinars. Email any questions you have to me. I have not received a whole bunch of emails, so either you're all getting it or you just don't want to talk to me. I'm just kidding. So I don't bite, I promise. Text and workbook. Follow your syllabus, which I have attached in the next slide, I believe. And read and complete all chapter exercises for all chapters. So that's what you need to do with your textbook and workbook. And typically, you should be watching the lectures, reading the textbook, watching the lectures, the whole thing. And then you go to Evolve and you complete each test for each chapter. So something that we noticed as we're going through is that there are some incorrect answers on the tests. And those tests are created by the makers of the textbook. We're not reinventing the wheel with the exams. So I had to go through and look at them to pull out the incorrect answers and switch them. So in fall 2015, all the exams are now posted. This gives you a more accurate idea of whether you get it or not. So if the test is correct and you get the correct answer, you feel better than if the test is incorrect and you put the right answer and it tells you you're wrong anyways. So use the fall 2015 exams because I went through them. That's not to say that I'm perfect. I may have missed one here or there. But they're certainly more accurate than some of the others. Each chapter has to have a test grade, all right? So when I go on to check my test grades for you guys, we've got some catching up to do, all right? So I urge you to complete your exams. If you've done all this work, you want your certificate, finish your test grades. Outside of an abject failure on the test, it is much more important to me that you've given it a shot and you've, done your reading and exploring there. So finish those tests. All right. Final assignments, email to the school. Do not snail mail. Your resume, which we talked about in the last class, has to be emailed. Your assignment checkoff list needs to be completely filled out. Your name, as it should appear on your certificate, should be on it. And the link is here. And so, here, you have the instructor contact. You have the syllabus posted on Evolve with my contact as well. You have the assignment checkoff list. This is what it looks like. So print this paper out, fill it out, scan it back in, fax it or email it with your resume to the address down here, info@academyofmedicalprofessions.com. All right, so on this line, your name, as you want it to appear, needs to be there. Be as clear as possible. So you've got to make sure that people can read your handwriting. Your start date, your completion date, and my name should go here. That's Kelly Rose. Checking off these dates here that all work is done. I would assume that you can check them, but we're going to make sure that that the work's been done for those two. Your syllabus here. Okay. And so everything you need right from this presentation. All right. So now that you have the building blocks, you have my best wishes for a successful career. And I mean that sincerely. It's a new experience for me not being able to see all of your faces as you're doing this. And I just hope that you will reach out if you need human contact about this. And if I haven't communicated it well enough yet, I love dentistry. It has given me a career that is more than 25 years of flexibility, satisfaction. So I love the field, and I hope you will too. Thanks. just wanted to take a minute too before, I know I just said goodbye. But if you're still here, I just have a couple things I wanted to show. So, I wanted to show what the elevator looks like and how big it is. So it is like this, okay? Not a huge instrument. But when I transfer this, I keep the working end tucked in my palm, and I'm doing this. A lot of times this is done under the chin so the patient can't see it because it's kind of threatening looking, or it's done out of their ear sight. And then the forceps, there's lots of pictures in the textbook of forceps, but it's always interesting to see the size of them, actually. So a forceps is used like this. So the dentist keeps a finger or two in between and operates with the rest of the hand so that they can control it better. So there's those. And then I have two little pedo forceps. Aren't they cute? So these are for extraction of on children. They're adorable. So that is my scalpel handle. Couple things. One thing here. These are the needle holders. And that's it. Okay, let's get started with week 9. Week 9, we are finishing up restorative impressions, prosthodontics, and then we're going to do a little on the job search, resumes, cover letters, and some tips from me to you. This is our second to last class, and next week we will be completing with specialty practices. So we're picking up where we left off last week, which was at the tail end of restorative. And at the end of class, I asked that you read through this chapter because there isn't a ton outside of watching and doing that will prepare us. But we are going to look at the two types of restorative procedures, which are direct and indirect. Direct procedures are done directly in the mouth. The main thing to this is that the material is still soft and pliable, and then is set and shaped in the mouth. Everything is done directly in the mouth. Indirect are done in a laboratory by a laboratory technician who shapes the material. The restoration is then cemented into place by the dentist. So an indirect procedure is when the dentist makes room or makes shape for the material, but the laboratory technician makes the material, and then the dentist cements it into place. So there's a waiting time between getting ready for this restoration and actually having the restoration. Direct restorative procedures, operative dentistry, amalgam, composite, direct resin veneers, tooth whitening. The steps for direct restorative procedures are cavity removal, tooth preparation, the liner base and bonding system, and placement of the amalgam or the composite. Matrix systems need to be used when we're placing amalgam or composite. The temporary wall, hold on a second here. Okay. So the matrix system is for being an extra wall that's been lost to the disease process. So when we're doing restorative dentistry, we need something to pack our pliable material against, our direct restorative material. For class 2, which is a posterior amalgam, we usually use a universal or a Toffelmeyer band and retainer. For class 2 composite, posterior composite, we'll use a Paladent or sectional matrix. And for class 3 or class 4, which is the anterior composite, we're going to use a Mylar strip for those restorations. A wedge is also necessary with the matrix system. So let's take a look at those after we get into wedges and bands. What wedges do is they prevent the material from going too far over the tooth, which is a plaque trap. And they are placed at the lingual. How are you going to get a wedge to a dentist? They're very small wooden things. You're going to hold your hand out with the wedge in it and then transfer the cotton plier and the dentist can take it. Or you can transfer the wedge and the cotton plier together. How many do you need? 1 for an MO or a DO, 2 if it's an MOD. The size will be selected by the size of the embrasure. So how big is the space between the teeth tells me how big my wedge needs to be. Bands are typically the large side goes to the occlusal and the retainer sits at the buccal. Now this is probably, if you haven't read this, you're going to be like, what? But the pictures will clear it up a little bit. So the slots on the retainer go to the gingival, and then we burnish this on a paper pad or contour with a Mylar mirror handle. Okay, so my wedge, my slot facing gingival, so that's the slot part of it. My wedge coming from the lingual, and this is my temporary band. So this is the Toffelmeyer or universal retainer and band. And the band is my temporary wall. The wedge keeps the material from falling down as I pack it in. So this is what wedges look like. Universal band, molar band, and the Toffelmeyer retainer. Molar band has 2 bumps on it. Okay. The Paladent system, which is for the posterior composite, looks a little bit like the clamp for a rubber dam, but it's not. It has a thin section or sectional matrix piece that wedges in between the teeth. So this clamp and little put together is almost like a retainer and wedge in one. And the band goes around, and the wedge can also be used this way. So we're taking this and we're kind of making it, we're taking this and we're putting it in one. The advantages of this for posterior composites are that the material is much thinner and is going to give a better wall for the dentist to work against. Also greater separation of the teeth so that the contact is greater. These are Mylar strips, and Mylar strips help us to establish the contour, make that temporary wall for an anterior tooth that has lost structure due to decay. So this is a class 3, all right, so the incisal ledge is still intact, so it is not class 4. But I placed this beautiful piece of plastic here, and it allows me to cure my composite through it. Remember that composite is light cured with the little blue light, and I can make it rebuild that patient's tooth, matching the colors there. And there's my wedge. For anterior composites, the wedge can either go from the distal or the mesial, depending on dentist preference. I mean, the lingual or the buccal, sorry, depending on dentist preference. Direct composite veneers are something that are pretty popular. And these are done in the mouth. So they're direct with composite. And a veneer is like a fake fingernail, but it is for the tooth and not the fingernail. And it's not made of acrylic. So this is a direct composite veneer. And I can take this and make it that. I can take this and make it that. And I can take this and make it that. All right, so these are pretty cool. And this is all done right in the mouth, single visit. What is direct composite veneering? This will walk you through the steps a little bit and give you an idea of which ways this goes. And this reminds us of some of the materials and burrs that we looked at last week. So take a look through this slide. Let's talk about vital bleaching for a minute, because tooth whitening or vital bleaching of teeth that are still alive is a real practice enhancer, but people really want this. People really want whiter teeth. What do we have for ways of getting there? We've got the in-office, one appointment, laser enhanced treatment, very expensive. And you can see I have 3 to 4 dollar signs here. That means in the hundreds to possibly the thousands, depending on the practice or the area you're in. And sensitivity is the biggest problem with this. We have the professional at home, which a patient comes in for an impression. A custom whitening tray is given the materials, and they do it at home. And this is usually in the hundreds. 2 to 6 weeks for results for this. And then there's the over-the-counter. And if I had a nickel first, every time someone said, does the over-the-counter really work? Yes, it does, but it doesn't give you a lot of whitening. So does it work? Yes. Is it going to give you the professional results? Nope, it's not. And these are usually, in the tens of dollars, meaning from, 20 to 70 for most systems. What is in these things? Peroxide, hydrogen peroxide, or carbamide peroxide. Carbamide is the professional formula. Hydrogen peroxide is the over-the-counter. The higher concentrations are faster, but they can cause sensitivity. What does it do? The OxyClean commercials, lightens and brightens, and it's basically what it does. It allows oxygen to enter the enamel and displaces colored compounds that sting the teeth. Typically, we can get 5 to 6 shades of improvement. That's pretty good. So quiz yourself with the next few slides. Identify these steps for restorative procedures. How will you explain the procedure to the patient? So what will I say? I will say, so I'm going to ask the patient, have you had a filling done before? And if they have, maybe I don't have to do much explaining. But I may say to the patient, so we're going to be placing a filling on your upper right molar today, and do you have any questions for me? And that gets the dialogue going. And the dentist's hands in this slide indicate that the Mirror and Explorer should be transferred. So two-handed simultaneous pass, and that's ready position that we're seeing there. This is topical anesthesia. This is called, and what does the arch indicate here, or what does the color of the needle indicate? So this is local anesthetic, and that is the mandibular arch that we are working on. Identify each type of moisture control here. And we've got cotton roll, rubber dam, and triangle. What is this setup for? This is a rubber dam setup. Name the 3 implements and their function in cavity prep. And so we have the one that shoots the water and has headlights. We have the attachment that holds the small bars, and that would be the contra angle and the high speed. And this is a cross-cut straight fisher, if you're real good. And we have the spoon excavator here. Notice how it looks like a spoon? Nice and rounded there. Their function is to remove decay and prepare the cavity walls. Just as an aside, I don't know if I mentioned this before, but if I didn't, I'm going to do it again, even if I did. 2x2s always go with the spoon. Dentist wants to wipe whatever he pulls out of the tooth off so that he can go back in it and get some more. This is a round bar, probably a 4 or a 6 in this handpiece here. Name the use of each material and the implements used to place it. So if you're watching, it's a good idea to sort of put this on pause so that you can really quiz yourself with this. So pause it, take a look at the slide, write down what you can, and then you can listen to me say what's what here. So this is calcium hydroxide, and this is used for lining the tooth when decay is deep. Keeps irritants away from the pulp. This is glass ionomer. This is a base and a liner together. This is the Di-Cal applicator, the spatula, the paper pad, and here we have prime and bond and some micro brushes. And again, take a look at the slide and then pause. So the systems used above and what material they are used with. So this one is for posterior composite. So I've named the material and what this is Palladent. And then this is the universal or Toffelmeyer retainer and band used for posterior amalgam. Identify by name and function. So this is the restorative setup, and we're going to name the instruments and their functions. So you can put it on pause, take a moment to do that. We've got Mirror Explorer for checking the tooth, cotton plier for transferring small instruments. These are the examination instruments. We have 3 hand cutting instruments here. And I'm not even going to make an educated guess on some of them, but I will tell you that there is a spoon here, there is a chisel here, and there is either a hatchet or a gingival margin trimmer. Their function is to remove diseased tooth structure and place grooves and refine perforation walls. So these are hand cutting instruments here. And then in section 3, we have restorative instruments. We've got the condenser, which will push the material down into the preparation. We've got the burnisher, which smooths the material. We have the clear discoid carver, which is used for occlusal surfaces, and the Hollenbeck carver, which is used for interproximal surfaces. This is the amalgam carrier that brings the amalgam to the preparation, the amalgam well, where the capsule is broken open, and the articulating paper and articulating paper forcep, cotton rolls, and 2x2s. All right, what are these used for and in what order? What is needed with these discs, and which order will the burrs be used in? So take a moment to pause it. And we will go through them now. We've got coarse, medium, fine, and superfine discs, which require a mandrel for use, and they will be used from lighter back towards this way, and I'm surprised that this one is in a dark blue, to be honest with you. But so they will be used from this way to that way. So we're going coarse, medium, fine, superfine, which blows away everything that I know about how the colors work. So this is an interesting kit, isn't it? So these here are cups, points, and wheels for composite finishing. All of these are used for composite finishing on this slide. These 3 diamonds will be used coarse to fine, and that would be red, yellow, and white being the finest. And if you look at this, you can actually see that, looking at these, which one is more coarse and which one is less coarse. We have some enhanced points here, cups, discs, and points, and then the polisher is used last. We have some interproximal strips that are used to finish the in between the teeth here. Those are fine on one end and rougher on the other. And then we've got some glossy paste that's going to be used with these. And all of this is for composite finishing. Okay. That brings us to indirect restorations. And indirect restorations are, and you can chant with me, crown, bridge, inlay, onlay, veneer. I make a little chant out of it so that I can always remember which ones are indirect, which ones need to be made in a lab, or milled in the office using CAD/CAM technology, which is grabbing the dental world by storm. So crown, bridge, inlay, onlay, veneer. And if you go back to our first lecture, our first time together, you'll see that I had an example of crown, an example of bridge, and then I'm going to show you some of these as well. These are made from gold that is mixed with another metal, so they're not pure gold, but they're gold alloys made from porcelain or a combination of both gold and porcelain together. And whether the material looks gold or it looks a silver color to your look, realize that gold doesn't always look gold. So I have my wedding ring and band are both white gold. They don't look like gold, but I couldn't afford the platinum and I wanted the white look. So remember that not everything that is gold is actually gold, and not everything that doesn't look like gold isn't gold. So dental uses gold and porcelain or a combination of both. There are newer fiber reinforced materials that are made, they're compressed together in a lab under pressure, and those are also really good materials as well. There are steps that we're required to do in the office and then the case is sent out. Usually it's a 2-week turnaround on average, so a patient is going to wear a temporary restoration for the time that they are waiting for their permanent to come back from the lab. And when that comes back, the dentist cements it into place. And this is the overview of the crown. So a preliminary impression is taken with alginate material. the tooth to be crowned and the opposing arch are both taken. So if I'm having a crown done on my lower right, I need the opposite teeth, which are the ones that bite against it. That would be the top ones, right above it. And I need the tooth that I'm going to have crowned. These impressions are used for models to make a custom tray or for temporary crowns. The dentist prepares the tooth with diamond burrs. A new impression of the prepared tooth is taken with a different type of material, elastomer material. The tooth to be crowned and or the opposing arch. A temporary crown is made and cemented into place, and then the patient returns in 2 weeks for their permanent to be cemented. So we talked about cements, and we had, a different way we mix our permanent cements versus how we mix our temporary cements, and different materials used for each. So temporary crowns, temporary cement, which is mixed thicker than permanent cement for permanent crowns. That's thinner. Okay, so let's take a look at some of these. Our materials: metal, porcelain fused to metal, or all ceramic. What is the metal? It's gold. Does it always look like it? Nope, but it is. And this is a bridge. A bridge has one anchor on either side, and then the false one in the middle. You can have more than one false one attached to it, and but your main thing is you've got to have at least one anchor on either side most of the time. There are some exceptions to those rules, and that's advanced crowning bridge. This is a veneer, so it looks like a fake nail, but it is for a tooth and not a fingernail. The crowns are just single units that go over a little stump of a tooth that the dentist has prepared. So we've got some graphics here to help us understand a before bridge, after bridge, and then single crowns before and after. The last slide shows me inlays and onlays. Inlays are within the cusps of the teeth, and onlays go over the cusps of the teeth. So both of these are onlays, and this is an inlay. And if you look here, can you tell which is which? Inlay, and that's likely a full crown there, but could be onlay if we wanted to stretch it. Okay, so restorative procedures, what do they include? They include crowns and fillings, any procedure that restores form and function to the existing teeth, roots, or implants. Veneers are considered a restorative procedure. To sort of make why we distinguish this hit home, it's not part of what we talk about in the course, but there's a business side, obviously, to dentistry. There's a business side to medicine, that healthcare costs money. Dental care costs money, as many of us know. Dental care for charging our patients is broken down into sections of the code. Now, we talked about this with HIPAA a million years ago at the beginning of the course. But one of the things that HIPAA did is it took all of the procedures in dentistry and it lumped them into categories that all dental offices use. So if I speak dental, then I need to speak where those procedures are, because I may have to use them when I use electronic charting to figure out where I'm going and where I'm putting them in. So what kind of procedures do I find in restorative section of the code, or the dental terminology? I find crowns, amalgams, composites, veneers, crown buildups, posts, cores, things like that. All right? Okay, and we're going to move on to impression materials and lab procedures. And if you'll just bear with me 1 second. It is a little bit chilly. Okay, so impression materials. The impression is the negative of the teeth, the gingiva, and the surrounding structures, and it's used to make a positive. It's used to make a copy, typically a stone model or a casting. And we saw this way back in the very first lecture when we looked at that together, because it's a basic thing to understand in dentistry is what the negative will give me. And then this is our chapter where we understand all the different things that I can do with it and why I have to have it. So think about building a sandcastle on the beach, or think about making an ice cube. You're taking something that's empty and you're filling it up until that thing sets. How do they make those somethings that are empty? Well, they're the negatives of something. So, what types of impressions? What will they be used for? The purpose of the impression tells me what material I will use, typically, in the office. So the first type is the preliminary impression. This is taken with alginate or an alginate substitute and a stock tray. A stock tray comes off the shelf. It is taken by the dentist or a qualified assistant. Hygienists can also take them. It is used to create a model for either diagnostic models for patient presentation, for custom trays for bleaching, for custom trays for dentures, for making a temporary crown. So if I need to do any of those 4 bullets there at the bottom, then I'm going to take an alginate with a stock tray. Final impression is taken only by the dentist. It is taken with a material that is elastomeric. It is taken of a prepared tooth or a tooth that I've drilled. And it is used by the lab to fabricate crowns, bridges, inlays, onlays, veneers, dentures, and partials. So if I need to do any of those bullets at the bottom of the slide, I will use elastomeric material, and the dentist is the only one who can legally take a final impression because we're making something final for the patient. So the dentist stamp has to be on it. The last type of impression is the occlusal or the bite registration. Bite reg is how we usually talk about these. I like to shorten everything, excuse me. These are taken by the dentist or qualified assistant. We ask the patient to bite gently and naturally, and we use either wax or kind of like a Cool Whippy sort of consistency elastomer, with or without a tray. And what this does is it accurately records the way the patient bites together, or their centric relationship of the maxilla and the mandible. How are your teeth centered over each other? Lab tech and doctor both use these to mount patient models and to make sure that the restoration that they're making, that final crown, bridge, inlay, onlay, veneer, denture or partial, sits correctly in the mouth. So if you can't bite on it, it doesn't work, right? So we need to have that bite reg to make sure. All right, let's talk about, so those are our 3 impressions: preliminary, final, and bite. Let's talk about trays. Stock trays come off the shelf, and they can either be full, quadrant, or anterior. They are made of gauze, they're made of plastic, they're made of metal. If they're made of gauze or plastic, they are typically disposable. Metal trays, reusable. Got to clean them, got to autoclave them, reprocess for the next patient. Custom trays require a preliminary impression with a stock tray first. But a custom tray, the advantage is it only fits that one patient. And I can make a custom tray for a patient out of acrylic. I can make it out of a thermoplastic, which is that mouthguard material that we saw. So we do, very back at the beginning, we talked about this. Or I can use a light cured resin. So I have some options there for my custom tray. All right, now we're going to talk about the materials themselves. Alginate or irreversible hydrocolloid is for preliminary impressions. It comes from seaweed. It's only grown off the coast of Japan. But this seaweed is also used in ice cream and lipstick. It's everywhere. So when your patient says, what is in that stuff? And you say seaweed, they get all grossed out until you tell them, yeah, it's in half the stuff we eat and lipstick. So it's a thickener, basically. So why is it called irreversible? Because it starts out as a water and a powder, and then it turns to a gel, but it can't go backwards. So once you mix it together like brownie mix, you either get brownies or you stay as a soup. You don't get your powder and your water back. Normal set for alginate is 2 minutes. Fast set alginate is much quicker, and the working time is much faster as well. So working time is the time from the mix to getting it set in the mouth before it no longer has any elastic properties to it. So if you're fast and you're comfortable with it, you can use fast set for a lot of things and save yourself time. Patients are much more comfortable with fast set because, it's not a pleasant procedure sometimes to have an impression taken. Warm water accelerates this. So about 80 degrees is warm. That's above room temperature. Cold water will lengthen it. Why would you ever want to lengthen it if you need more working time? They're mixed in a flexible bowl with a spatula, and I'm going to show you that. And I think rather than do that and read through it, I'm going to leave the screen up there, and I'm going to ask you to follow me down to the end, and I will show you the alginate material. Sorry, guys. You'd think. Okay. That should give me enough room for you to be able to see it. And assuming you can still hear me. Okay. So. Just put my gloves on. Okay. And this is my alginate. Right here. Comes in like a coffee can sort of deal. And this is my flexible bowl. I've got some stock trays here. It's really hard to stay so far away from the camera that. Okay, let me see if I can get this to come in a little bit better before I start making a mess. Okay. All right, let's give that a try. So, you remember, I went to dental school and I had to learn how to work in a mirror, and that's challenging to learn how to work in a mirror. You wouldn't think so, but it is. Now, I'm trying to work in a mirror here too, with my whole body instead of just a finger instrument, and it's more difficult than I would imagine. All right, so I've got my alginate in a canister, I've got my flexible bowl, and I have my spatula. Okay, I'm going to set this aside just for a minute. I'm going to show you that I've got my water measure right here. It says, and I know that's hard to see, but it's got 3 lines on it, and it tells you 3 scoops or 2 scoops or 1 scoop. So however many scoops of powder you put is how many water measures you need. Alginate is a 1-to-1 ratio. I have some stock trays here, and this one I'm going to show you compared to this one. Let's see if we can get them both on there. It is imperative that you tell the difference between the two. One of them has space for a tongue, and the other one does not. So, the one with the space for the tongue is your lower. This is the upper. The palate is filled in. We have to be able to tell the difference. There's nothing more frustrating than the wrong arch tray when you have your impression material mixed. And these come in different sizes. And I do also want to show you that I've got a quadrant, so I have just half of an arch, or I've got a section, which is just the anterior part of the arch. Right. Okay. Now I have my Type It On here, and I think, okay, we've got lower and the upper. Good. And hopefully you can see that a little bit. Now, alginate is dusty, and you should have a mask on when you measure and use it, because you do not want to breathe it in. So I'm tapping the powder to get an accurate measure, and then leveling off my scoop. The scoops come with the stuff. They're not always inside the canister, but they're attached to it or close by. And I've got 3 measures of water here, so I have 3 scoops. And I am taking the impression of the upper, but I will also walk you through the lower as I do it. So I'm going to show you how to mix this. Okay. Some people start with the water. They tell you you're supposed to. I never have been able to do that. So I add my water, and I am mixing. And once I get all the powder incorporated, I start spinning it around in my hand. So the bowl is in the palm of one hand, and I am beating it against the sides of the bowl like this. All right. Because I am taking an upper, I'm going to grab my upper tray and all of the material at once onto a spatula, and I'm going to load this from the back, just like that. And see, as I do that, how the material just kind of flops itself forward. That helps me to eliminate bubbles and get a really nice impression. Okay, I want more of my material in the front than I do in the back because I don't want to gag my patient. I am going to, see this on there, I'm going to place it in the back first, and then bring it down over the front of the teeth. I'm going to make sure to flop my patient's lip over the anterior part of the tray, and then I'm going to hold it with 2 fingers, just like this in the patient's mouth. So if I were to turn this upside down, and I've got my patient here, my fingers are in their mouth the whole time. I don't want them to bite down. If they bite down, they're going to distort my impression. And I'm going to leave that there, and I'll show it to you as soon as it's set. This is regular set, I'm pretty sure. Yep. And it should take a few minutes to do. So with the lower, when you seat a lower tray, you're going to seat the back first, posterior first, down over the front of the teeth, and then you're going to ask the patient to lift the tongue. So you don't want the tongue trapped next to the teeth, or you won't get a good impression. So the tongue gets lifted. If you've got a gagger, you need them to breathe through their nose, don't talk and bite. And we're almost there. When is this ready? How do you know? You don't want it to leave a fingernail mark when you push against it. So if you can leave a mark in it, as I just did with my fingernail, then it's not ready yet. And if you pull an alginate out before it's ready, you will have a very unhappy patient. So my funny story, in dental school, I had been taking impressions for many years at that point because I was a dental assistant for 10 years before I went to dental school. So I had a big crush on a guy who was in my class, and he took his very first alginate impression on me. And he didn't think he seated it right, so as soon as he put it in my mouth, he pulled it out. And so I was left with a mouthful of unset goop. and I had to wait until it set before I could peel it all out of my mouth. I was probably the color of a traffic light by the time this was over. I was so embarrassed. It was rather awful. He was worse because, of course, it was his mistake. Don't pull it out before. All right, so my impression is set because I'm not leaving a mark with my fingernail when I push on it, and that is good. So I'm going to pull it out, and I do this with a snap motion, and I typically go to the back. Just kind of pop it up, and you hear that pop. And my Tepidon is missing a few teeth, so you'll see those there as positives. But this is my impression. This is what it looks like. So I get a nice exact copy of the negative of this, and I can pour that in stone and come up with a positive. I'm just going to trade that blow in. I'm going to advance the slide, and then we're going to come back and I'm going to show you elastomers. So that was alginate. I'm going to skip the model for a moment because I do not have the equipment to pour the model. But we're going to talk about the second kind of impression, the final impression, which is the elastomer. Elastomer is rubber-like once it's set. And not all of these taste wonderful. The one that I'm going to show you doesn't have a bad taste or smell, and patients typically do well with it. It comes in different weights, and the most popular way, let me just move the alginate stuff out of the way here. The most popular way that these materials are used these days is with gun and cartridge. So this is a cartridge, and this is an impression gun. The proper name for this is auto mix, but you very rarely hear that in the dental office. We've got a cartridge yet. Whether that will stop being PC, I don't know. But so inside of this cartridge is a base and a catalyst. So in every cartridge, we've got base and catalyst. And what this does, once I load it into my gun, you see I just slid the cartridge into the front and closed it, is allows me, once I take my cap off, to attach a mixing tip. And the mixing tip will allow me to mix those two together. Before I do that, I'm going to show you how to test this. So when I test one of these, I do it on a 2x2 and I just express a little, and that makes sure that this is going to work when the dentist asks me to go ahead and start mixing. So let me put my mixing tip back on again and make sure it's locked. What I have on here is a syringe tip. The syringe tip is for the light body. The light body typically, you can see this, I hope, goes around the tooth that is prepared for the crown. Like this. Okay, and then I would get a new gun with a new material. And I would load my tray. And the tray is typically a gauze tray. Sorry. the tray is placed in the mouth. And what that ends up looking like is this. So what we have is a two-tone impression. Light body for syringe, heavy body for tray. That allows the bite. So it highlights the preparation of the tooth. Sorry about that. The coughing got me. Okay. Okay. Okay, so to continue on with this, there are some different kinds of elastomers. The most notable of the elastomers is the rubber base. It smells like sulfur, so it smells pretty bad, and it is used for dentures mostly, if anything. The others are going to mostly come in the guns. You are going to have a light body that you transfer first, and a tray material, which is either regular or heavy, that you transfer second to get that two-toned impression that I just showed you there. These can be mixed on a paper pad with a spatula, or if they're a putty, they can be mixed in your hands, just like Play-Doh. But most commonly, the gun and cartridge we see. The technique for the final impression is that the dentist isolates and dries the tooth, gives you the ready signal. You transfer the syringe with the syringe tip on it. The dentist will syringe the material around the tooth. While they're doing that, you're mixing the heavy body. When they signal ready for the tray, you transfer the tray loaded with the tray material and or heavy body. And the dentist seats the tray, and then 5 to 6 minutes later, the impression is removed from the mouth. We disinfect the impression, label it, and place it in a biohazard bag. This is most often sent out. Do not pour it. So we don't pour final impressions, okay? Now, pour. What is this pour? Pour is what I skipped here. We're going back to it. Pour is the act of making the dental model. So we say we're pouring a model, meaning we are going to put liquid stone into it, and the stone will set to give us that tooth model that we see. So impressions are used to make the model, but what is the ultimate goal of the model? What is the purpose of the model? The purpose of the model tells me what materials I'm going to use for it. So we basically have two purposes. Either it is a diagnostic cast, which we're going to show our patient or the dentist is going to diagnose from, or it's a working model, which means I'm going to make something on it. So if I'm diagnostic cast, I am most often using model plaster. This is white, it's aesthetic, it's clean, it sets faster, it has a high water to powder ratio, which makes it weaker, which means that model plaster has the most water of any of the different gypsum products. The gypsum is mined from the earth. It comes from the earth and then it's dried into a really white powder, a really dry powder. And that's what this is, and we mix it with water to get stone or plaster back again. Excuse me. Sorry. Dye stone or dental stone is colored and stronger, has less water and more powder. It's more durable, and we use it to make something on. It's our working model. So those are the two types of models typically. The dye stone, the high strength stone, is the one that's usually used for crowns and bridges. And because those are poured in the dental lab, you are likely only going to see them when they come back from the lab. You're not going to use dye stone in most offices, but you will use dental stone, which is colored, and it is the medium. So we've got the model plaster, which has the most water. We've got the high strength stone or the dye stone, which has the least water. And we've got the dental stone, which is medium in water. So it's a good compromise between the two extremes of strong and weak. Stone is measured by weight and milliliters of liquid over water. Most offices eye this, and we have to get good at giving the correct consistency to our models. So I haven't measured plaster or stone in a very, very long time. I usually only do it when I am in a teaching environment. Because most of the time I can eye what I'm looking for and mix once. But when you're learning to do this, you want to measure if you can. And some docs will insist you measure because they understand the material and what it does. So we mix it to a creamy consistency by slowly incorporating the powder to room temperature water. I'm really sorry. If you watched me mix the alginate, I beat that and I really went quickly with it. But plaster is different. Plaster takes 45 minutes to set in stone. So gypsum you don't want to beat, because the less you mix it, the less air bubbles you will get, which means you'll get a prettier model. If your water is too warm or you add too much powder, you're going to get a faster set. So these materials are sensitive to you a little bit. And there is no substitute for just sort of knowing your material and then doing the right thing with it so that it gives you the expectation that you're looking for, gives you the result you want. You'd vibrate on a vibrator about a teaspoon of gypsum at a time into the impression, into the back of the impression, usually a posterior non-critical spot. We allow the material to flow on itself, keep building up. It pushes the air in front of it. And when the teeth and tissue are covered, you're going to shut off the vibrator. You can add more material to make your base or art portion after that point. The consistency of your Okay. The consistency of your stone and of your plaster should be that you could mix it and then hold it over your own head and not worry that it's going to come out. So if I hold it upside down and it drips, it's not a good mix. So I always say make sure that you can hold it over your best friend's head and they'll still love you tomorrow. So if it doesn't come out, you've got a good mix. You don't want it to flow too much. Okay, so the art portion of your dental model is the base. This is the part that you make. That's why it's called the art portion. It's about 2 inches by 2 inches in square and about 1 inch high. All right. That is not including the tooth part. So this is just the part that you make. There are 3 ways to get there, and the highlighted one is the most common. We make a patty about the size we want it on a pad of paper or a tile, and then we flip the impression over into it. The impression has already had the stone added up to the teeth. So we did this part before we did this part. Okay? So 2 other ways of getting there. Double pour, I can do this part and then make a new stone mix to make the base. Or I can put a box around it to do this part. I can take wax and make a little box around my impression, and then I can pour my stone mix into the wax mold, and that makes a shaped art portion. For anything that you're going to show a patient, and even for some that you're not going to, that you're going to work with, trimming is a great way to get a model to do and appear the way you'd like it to appear. Model trimming is done with the model trimmer and a wax bite, and it's done to a geometric standard. It needs to be pleasing in appearance, which gives rounded in the anterior, pointed of the maxillary. So rounded mandibular, pointed maxillary. The point in the maxillary is from canine to canine, so that's where my point starts, like this. And the sides and the back are trimmed to 1/4 inch parallel cuts. And then I have heels. And please bear with me. I thought I put a picture in there. I did not. I showed them to you in the very first class. They did not make it with me on this trip. But there are pictures in the textbook as well. There's a lot of this that can show you these. I found that there really isn't much substitute for measuring it out and practicing a few times, which you can do once you land in an office. There are going to be people in this business who are going to be on fire with letting you practice and teaching you these things. Where will you do the most of this? Orthodontics, unless they send them out. But I love model trimming. It's a lot of fun to do. All right, so we covered our elastomers. Did I miss one? Nope. Okay. Know your materials and know how to make a great mix. Keep the patient and the dentist calm by being ready and having all the materials needed. That's a lot harder than it sounds. It takes a lot of pre-thought to make sure that you have everything, which means that in order to know you have everything, you've got to be able to run through the steps in your mind. And the only way to run through the steps in your mind is to make sure you know them well, right? So review your procedures in your textbook and contact the school for assistance in continuing in the field. I believe that there is some, that there's assistance for getting you into an office if you're really interested and motivated to keep with this, because people in dentistry are natural teachers. So, because we have to educate our patients all the time. We get good practice at it. Okay, so we're almost to the final chapter for tonight, and then we're going to do our job search, which is a chapter in the textbook, but it's further along. It's the last one in the book. But let's look at prosthodontics. Prosthodontics, fixed and removable. Recall from, I'm sorry about the ums, good Lord. I get tired, and that's what I say, apparently. So recall from the very first class that prostho means fake or false. And a fake or false what? Fake or false tooth. So missing teeth can be replaced either by something that is cemented into the mouth, which is fixed, or something the patient can take in and out, which is removable. 2 types of prosthodontics. False teeth. Either they're stuck in there and they can't come out unless the dentist takes them out, or they fall out. or they are removable and you take them out every night. Those are the choices. So money, health of the teeth of the mouth, the anatomy of the mouth, the health of the patient, and what the patient wants determine whether you get the fixed or the removable. Fixed: crowns, inlays, onlays, bridges, veneers, and then we've got some resin bonded Maryland bridges they talk about. Those are not that common anymore because they used to fall out a lot. So we went over this in the restorative, but I just want to go through it again in a little more detail. So not the first time you've heard some of this, but definitely good to hear it again. First of all, crown and bridge is the bread and butter of most dental offices. That means that most doctors are doing 1 to 2 of these a day to keep their practice going, to bring in the amount of revenue that allows them to meet their overhead, keep their staff paid, things like that. So a single unit, a crown, an inlay, an onlay, or a bridge is going to go in this typical format. In the first appointment, we're going to take a preliminary impression, alginate, a shade of the tooth, unless it's gold, a tooth preparation with handpiece, an impression with elastomer, and then make a temporary and cement it to the tooth. That is appointment 1. For appointment 2, about 2 weeks from appointment 1, because the lab has to make the restoration, we will bring the patient back. We will try in that crown, that inlay, that onlay, that bridge, adjust it, and cement it if it fits and is comfortable. And the doctor is satisfied and everybody's happy. That's the timeline and what happens at the appointments. The highlights of this. Preliminary impression may not be poured. It might be used to make the temporary. And I'm going to go into that in a little bit. The shade should be taken wet in natural light. Tooth pep, if it is badly decayed or broken, a core or a buildup may need to be done. We will talk about this in endodontics a little bit next week, that a tooth that has had a root canal may have a post placed into the root and then a core. Posts often come in a kit or are cast in a lab to fit the patient. So there's a lot that goes into rebuilding a tooth that is broken or has had disease. So why do we do crowns on teeth? Because they're broken or they've lost too much structure to hold that filling anymore. And we've got to go to something that is going to hold the tooth together a lot better. Gingival retraction is a cord that pushes the gum away from the preparation and allows for the best impression that we can get. The provisional coverage, or that temporary crown, is used to protect the preparation while the permanent's being made. The most common is the custom. We take a preliminary impression and then fill it up with acrylic and stick it back over that repaired tooth, and you get a brand new tooth out of the deal. Those are cemented with temporary cement. All right, so the textbook has a lot in the procedures about this, and the pictures are good, and you should be able to work through it. But anything that is unclear, please email me, please. Okay. We're moving to removable prosthodontics, which is dentures and partials. I am not going to read through them, but I got a whole bunch of acronyms here that we use to talk about them in the dental office. Partials are supported by the remaining teeth. They are a metal skeleton that wraps around the teeth and sits in the grooves of teeth. Their teeth are typically acrylic. Porcelain tends to click. The appointments and timelines for a partial denture takes about 5 visits to make one. Preliminary impression for the treatment plan, custom trays, tooth preparation, final impression, and then we try in that skeleton of the partial. Make sure that it is sitting well, and the artificial teeth are then set on it if it sits well. we try that in too, and then we deliver. So one thing to realize about dentures and partials is that they're never going to be as good as what nature gave. They're never going to be as good as what was there. So patients have to have their expectations adjusted. Denture and partial patients are typically some of the most dissatisfied patients. So why do we keep doing them? Because sometimes they're the only option for many patients. You can get used to them. They take some time. It's like wearing glasses almost. Your eyes, if you've never worn a pair of glasses and you've got to start wearing them, it takes a while to get used to them. And imagine how often you use your mouth and your teeth, and how irritating it can be if you've got pain in there. So patients are not always happy, and adjustments are part of this process, and the patient has to really make sure that they understand that they're going to be coming back until they're comfortable. And we have to understand that too as dental professionals, because sometimes, they're not always the most fun patients to be around if they're not happy. So cheer them up and tell them to hang in there. Denture patients, worse than partials. They don't have anything of their own to hold back onto. We typically do 14 teeth on a denture. We don't do third molars, so that's 28 for the whole set if you're doing upper and lower. The top one is held in by the magic of suction created on the palate in the back. The lower is held in by nothing except what used to hold the teeth in. For many patients, holding a denture in is a miserable experience, and one that requires adhesive every day, and may not ever get good enough to be comfortable, honestly. What do we do about that? We do implants for them. The textbook does not go into implants. It's a little beyond the scope of a course like this, but implants are the thing of the future in dentistry too, because they're becoming so much more predictable. So I talk about implants with dentures because I can put a couple screws, or a surgeon, either a periodontal surgeon or oral and maxillofacial surgeon, can put a couple screws into a patient's jaw and allow the denture to snap onto it. And now all of a sudden, I have a denture patient who can begin to approach something like normal. Realize that you've got 14 teeth on one plate, is what most patients call them. So your brain has to retrain itself to having 14 individual functioning things all down to one. So it's a big adjustment to wear dentures, and it is not one that patients typically take to easily. And we've got to be patient with these patients. We've got to be understanding and empathetic. And when you're in the middle of a busy day, that isn't always possible. If you work for a doc who is less than empathetic to your denture patients, you fill in that gap. You be the happy person that they need to see. You be the encouragement that they need to have. I think it's one of the most important things we can do as dental assistants is listen to our patients and give them a venting board, even if we need to be pouring the impression in the other room, those kind of things. Sometimes the people relations are just really important. Accuracy of impressions is key with these, and the timeline for a denture is about 6 weeks. What do? We start with a preliminary impression. You getting there yet? Final impressions come next, and then we try in this big wax assembly that's supposed to be like teeth for the patient, so that we can tell the lab who's making our dentures where we want those teeth, and we tell them that by adjusting the wax. These denturists, people who make dentures, send back something so amazing from something you would never even believe could give them that much information. about a patient. People who make dentures are a wonder. Lab techs are awesome. Props to the lab techs. So they try and we then bring them back to try the teeth in, and everybody's got to agree that they don't get to be changed without a cost once they are processed to their completion. And adjustment of teeth. Now the textbook says 1 to 3 days, and as needed. As needed could be a very long time, just as a warning. Immediate dentures, what are they? In an abbreviation, they are what's placed after extraction. Immediately after extraction. That's why they're called that. So I could take out all 15 of your upper teeth right now and put in a new denture for you. And that new denture acts as a Band-Aid, and you get to go home and heal around it. And in a few months, when your bone is remodeled, we'll reline it and give you, or make a new denture, depending on, give you a new fit and feel to that once you've finished healing. What it does is keep you from having to be without teeth, basically an immediate denture. Relines are something that we do for dentures that don't fit well, and those are 8 to 24 hours in the lab, so the patient usually comes in the morning and then comes back at 5 o'clock to pick it up. So understanding the process of prosthodontics allows us to better assist the dentist and better provide patient care. A lot of times the doc doesn't need us chairside for a lot of these procedures. So if we set up well, we're freed up to drink coffee and go on Facebook now, to continue to keep up with our instruments and our treatment rooms, because our days are busy. So anytime you don't have to be chairside is a good thing. But if you forget something, they're going to call you away from whatever you're doing, and you've got to come back. So we try and go through and really get what our docs are doing, so that they have what they need. Okay. Our last trick for tonight is the job search. I'm going to post all these on Evolve like I always do. I have a bunch of documents that go with this, some templates. So here's my reminder to you. Getting your certificate, which I will cover all the things you have to do with the last lecture, which will also be on Evolve by tomorrow morning. You must email your resume to the school. So if you don't have one, this is how we're going to get there. But we also want an updated resume with some things on it that are targeted to dental, so that you can use the education that you got and bring it to an office. So first, you want to decide what's important to you. Your personal goals, how they fit with your family, your life, your education, and then your professional goals. Because if you don't know who you are, it's difficult to know what you're looking for out there. There are many different things you can do with dental assisting. Private practice, corporate dentistry, these are the two most common options when you're fresh out of school, because you are looking to get some experience under your belt. Insurance company sales reps, those are not two words. Insurance company, meaning dental assistants are sometimes employed to be part of the process of approval for dental treatment at an insurance company. A sales rep is someone who goes around to dental offices and sells dental supplies and materials for a company. Those are both fun places to do dentistry, do dental assisting. Public health, which is government-supported nonprofit, big clinics, VA. Trying to think of some others. Good places to work, definitely. My sister-in-law works for the VA in Manchester, New Hampshire, and she loves it. So, and that is your public health. There are many opportunities, too, for dental assistants in schools. So I know some hygienists and assistants who go around to schools and place sealants and do dental screenings. So you would assist with that process. Working in dental schools and in hospitals, there's a couple dental schools in Maine. Some hospitals keep dental assistants on staff and also have clinics attached to them. And teaching, of course, is a place you can take your education as well. Typically, you do need to be working towards a bachelor's for teaching, because you want to have more education than the people that your intended audience is. So teaching is something that you could move towards, though, if it interests you. And shout out to teachers, because teaching has really been good to me. I love teaching. So, okay. So here are my tips, some things from me to you, and some of these are in your textbook and others are things that I think you should do. And so I'm putting them here with my experience behind them, in the hopes that they will assist you in your process. Don't forget that your social media presence is a huge, huge, huge thing. You may have heard this before, and I may be speaking to the choir, but you need to make sure that you are managing your own social media presence in a good way. So if you have a Facebook account that has your full name on it, be prepared for whoever is out there looking at you as, as a potential employee, that they can see everything on your Facebook, because one way or another they can get in. Even if you're private, well, they may know someone you know, and then all of a sudden, friends of friends, and we're all there. So my suggestions are obviously to be professional and don't post anything that you wouldn't want your employer to see, but we also have private lives that don't always gel. That doesn't mean that you get to do anything you want to in your private life and still be a professional, but it does mean that you may want to keep some of that private. So what most people do is they change their name on there, and they use a nickname, or they use just a middle name or something like that, or some use their first name and their middle name to kind of change up what is associated with them. I would stress, however, that you never want to mention by name any dental employer, office, patient, anything like that on your Facebook. I had some former students who used to post while at work and say they were at work, and then wondered why they couldn't get a good job or couldn't find a job. So it's you really need to make sure that you're managing your presence. Create a LinkedIn account. Many, many employers check LinkedIn. And a LinkedIn account is easy to create, and you don't have to do a ton there, but it's a great networking site. So do that. And there's a link here. Create an account on dentalpost.net. The link is here. Upload your resume once you have it approved by us, because there are many jobs on dentalpost.net for this state and others. So you can travel if you have the right credentials. An employment agency may be a starting point. However, a lot of those require money. I don't know of too many who do that for dentistry. There are some temp agencies, and those might be a place, but most of the temp agencies want you to have some experience first. So you're starting up here. The Academy, of course, is a resource. Career Builder, Indeed, Monster, Glassdoor. Glassdoor is a fairly new one, but it's a really good one. Are all good search engines. Professional organizations, dental sales reps. Dental sales reps know everything about everything. They know who's looking for help. They know who's good to work for. If you know anyone who's in the business, ask them to introduce you to their dental sales rep, and then you too can know everything. Professional organizations like the Maine Dental Society, for instance, sometimes have meet and greets. They've got classified sections, things like that. Those are places that you can network through. Do not underestimate the power of word of mouth, especially in the dental field. Good joke, right? Okay. Use social media to network. So ask all your friends if you are looking for a job in dentistry. Somebody may know somebody. So lots of ways to do this, all right? Working interviews are something that are popular. Working interviews are a try it before you buy it. They are good for both parties, and you should be paid for the hours of the interview. I know many docs who don't want to do this, so make sure you agree to it ahead of time. Don't just assume. Do not do more than 2 working interviews in the same office unless you are comfortable with temping. Because there are some practices out there, and probably not as many, I don't know, it all depends, but I know many of my former students who got trapped into going back for a working interview like 4 times a month, and what they were doing was just filling in for somebody on vacation. The guy had never any intention of hiring them, and that's fine if you're aware of it, but for dentists, it's a cheap way out of hiring temporary help, and it's not. If you're trying to break into the field, you want to extricate yourself from that gracefully. Meaning, after the second interview, you either know you want the job and they know they like you, or they don't, or you don't, and that should be a place to respectfully cut ties unless you're comfortable with temping. Sometimes it's all we can get, and they do turn into positions, but so I don't want to turn you off on that. I just want you to be aware of it, so that you don't feel used. Ask before you go in about hours, dress, what to wear, breaks, lunch, lab coat. If everybody wears black every day, you don't want to show up in pink. And those things sometimes people forget to tell you unless you ask. Pack something to snack on that is non-perishable in your bag in case you do not get a break. And that, of course, may be the decision that makes you say, I don't want to take the job. But you want to be professional about how you handle it. So just because you're not getting what you want doesn't mean you storm out of there, because nobody will want to try you out again. Word gets around. So you are professional the whole way through. And you know what? Being hungry for a couple hours is better than, the damage it might do to your professional reputation if you walk out. All right. So stick it out for what you agreed to ahead of time. Make sure you know what hours they're looking for, and how it's going to go. If they can't give you a definition of that, that might be fine with you, but it might not work for someone else. So it's all about what you want. It's to try it before you buy it. Okay, your resume needs to be honest above all. Don't lie on it. You will be caught. It's a bad idea. A reflection of you. It should be unique. Leave out the I, me, my's. So don't say I'm looking for. Say seeking instead of I'm looking for. Use things that are domain specific, which means speak the dental language on your resume. So go into your textbook and go into each chapter and pick out something that interests you, that you learned well, that you're comfortable with, and throw it into your resume somehow, because that's what sticks out to employers. It should be interesting. It should be easy to read. And that would be interesting, easy to read. There you go. Okay, so I have a whole thing of those templates and other stuff depending on which format you use, whether you use Google or you use Microsoft Word. Got both of them. List skills from other jobs that you've had that translate. So if you have only worked at Dunkin' Donuts, that's fine, because you have customer service, you have responsibility, you have multitasking, you have, teamwork ability. You got all those things it doesn't matter if you don't have dental experience, if you know how to structure the resume well. Keep your focus on education instead of experience in your resume at this point until you get some experience, and then you can switch it. So you don't want experience to be the first thing they see. You want education to be the first thing they see, and then experience. So they can see that you've had some education in dental assisting, and then they can look at all the skills that you pulled out of the jobs that you have had. There's, from the textbook, page 5, for skills to list here. On page 5, box 1-1, there are skills in dental speak that you should know how to do and be able to put down. Only list a skill if you feel you can perform it. And I mean by that that theoretically I could say to you, how do you take an alginate impression? And you could describe it to me. We know that you've not been able to put your hands on these things. And dentists will ask you about that. And you will say, I know how to do it. I need the chance to break in. All right. And that's how you get what you're looking for. Collect as many dated letters of reference from your supervisors as you can. So anytime you have a good working relationship with someone, ask them for a dated letter of reference. Have a template for those who might be too busy to write it for you. And always ask before listing a person as a reference. And I have a template for you for reference letters as well. References do not have to go on your resume. You can say on request on the resume, but make sure that you've got some to offer if you say so. So let's look at the soft skills. And soft skills are the things that we do as people that help us to be better in healthcare. The next few slides is from a book that I helped to author. It's called Soft Skills for Health Professionals, how to get the job that you're looking for. So there are some things here. Who you are, positive mental attitude. You choose what you bring to work each day, and you've got to bring it. You have to leave home stuff at home, personal stuff at the door, and bring in a good attitude to work. Now, I, above all people, know how difficult that can be sometimes, especially if your life isn't quite where you want it to be. And even if it is where you want it to be, if your toddler threw up all over your shoes this morning on your way out the door and that made you late, it is going to change your attitude. But how you deal with these things are what make employers, excuse or not excuse, or overlook some things. We're all human. It depends on how we approach our human qualities and what we bring to it. Honesty, integrity, absolutely important. Be adaptive, be flexible, be tolerant. Realize they take time to learn though, and you got to practice. Being ready for work, model business etiquette, meaning what cues are the people around you sending? So if you've got a job or you get hired at a dental job that you want, look around and be cognizant of how you fit into the culture. Dress appropriately, practice good grooming, review what's written down for the dress code and follow it, even if nobody else is, until you are an accepted member and you find out why they don't or why it's okay that they don't. So remember that new employees follow different rules than seasoned employees do, meaning it's not always fair, but it is always real. That is kind of real. Cover your tattoos, cover your jewelry, minimize your scents, your makeup, your hair extremes. Don't say anything, I know. It's a joke. I was supposed to have red highlights, and this is what I got. Neat, clean, pressed. You need to be ready to go. There are cues that people read if you are not, and that's what you're looking for. So one of the suggestions I give is if you are in a new environment, pick someone to emulate, someone that looks like they got their stuff together, and you would like to be like that person. And watch, observe. There is no better way than to watch and see. And we, as humans, we often absorb what other people give to us if we're observant. So our facial expressions will mirror theirs, etc. All right. This is the point in the presentation where everyone likes to go, oh, and nobody likes to be preached at. Some of you are on the preachy side, and some of you are like me and need to be preached at. But get appropriate sleep. Get 6 to 8 hours a night. Your body heals during sleep. If you eat crap, you get crap. If you exercise, plan it at key times during your day. One of the things to do is if you know you're always tired after lunch, then plan your get up and go activities for after lunch. Positive interactions, laugh a lot. And that will make you seek out and be more satisfied at work, for sure. Be easy to deal with. That builds trust in your coworkers. When you use your name, when you use others' names, when you are sincere in your compliments, when you ask to help, even when you ask for help, you are building trust in coworkers. Be aware of the things that you say. I'm stupid. I'm never going to get this. Don't do negative talk to yourself. Or at least if you do that, be aware you're doing it and try and change it. That's what will help to build trust in you as a person. Be empathetic, be sensitive, and develop situational awareness, which means that if everybody's quiet, you are not screaming. Situational awareness means that you are tuned into your surroundings to know what is appropriate and when. I have worked with so many dental assistants who still needed to work so hard on this situational awareness. And patients can be very, very sensitive to this. So, for instance, if the dentist is talking softly and quietly to a patient, there's a reason they're doing that. And you don't want to either call attention to that reason or break the mood that the doc is trying to create by being loud, by being inappropriate, or by being insensitive. And then there are other patients where loud, inappropriate, insensitive is what the dentist is with that patient, because that's how that patient responds. And then, so you want to know when it's appropriate to do certain things. And that comes with, being curious about what's going on around you and really taking it all in, taking the focus off yourself and onto the others around you. Dealing with other people, there is always conflict at work, in any business mostly. What causes it? Insensitivity, the not my job thing, thoughtless words, cliques, financial pressures, and personalities of others. The best way to deal with this is practice reframing, which means change your perspective. And it's hard, but check your impulse control. Find common ground with other people, exchange ideas, change the way you look at stuff, and you may find a great deal comes back to you when you do that. And of course, being culturally proficient is a big deal. That means that all cultures are welcomed and valued. And you've got to really buy that. And that is, how do you do that if you're not there yet? Be curious. Learn about people. So, if there's and I'll use this as an example. My husband works with someone from India, and when they first met, the guy spoke probably 5 words of English. And my husband loves people, and he was so, they're the best of friends now. They do a million things together, and they're 20 years apart in age. But my husband was curious, and that's what allowed this man to open up to him. And there's a great exchange of ideas that goes on between the two of them. They work together. That's what you do, is open yourself up to your patients, be curious about them, and you see where that comes back to you. It's pretty cool. Just as this is a good slide to sort of put yourself back to if you're shaking your head and you can't understand a generation that is not yours. So Gen Ys are the millennials. They are comfortable with technology and they like to collaborate. And they typically are pretty close with baby boomers who were born between 46 and 64. So that's the generation in between sometimes can be left out of this. And they're more flexible in their what they're looking for a work-life balance. And then there's the great generation, which are before the baby boomers. And these are your wisdom sources for sure. So just take a look at the generations and sort of see, where you fall, and it helps you to understand those generations' motivation. Speaking and writing professionally is important. How do you do that? Read some more, read again. Get rid of slang and profanity from your language. Keep the TMIs way down, all right? So TMI, for those of you who don't speak text, that's too much information. You do not want to overshare. Recognize your audience cues, too. If someone is looking at you funny or they're looking away, it's usually, they want you to take notice of something. And so take a look at that. Leave behind a great record that shows your tone when you are writing. And in the dental office, your writing is going to be limited to the charts most of the time, but you may be leaving messages for coworkers. Emoticons. Well, I'm guilty here. I love emoticons. Emojis are my life. No, I'm just kidding. But don't use them in professional writing unless you have developed a relationship with the person and you understand that they're going to take them the way you mean them. Because otherwise they just don't have a place. So if I'm texting my boss that I'm out sick, I'm not going to send him like the shot and some Z's and things like that. I'm going to be professional, even if I'm using a text message. Be clear and informative. Leave out your opinion. Nobody cares about it, and I don't mean that in a bad way. What I mean is that your opinion has no bearing on professional writing. Unless you're writing an opinion piece. So if you're writing in the record, you are not going to say things like, I thought the patient was a jerk today. You are going to say, patient seemed agitated. Or patient said, and then quote them. But don't give your opinion about that. Okay. Your telephone voice. Speaking loudly and clearly, rehearsing your greeting. So, like, hi, this is the dental. So you couldn't even hear me then, right? That was purposeful because you need to be clear when you speak. We all need rehearsals on a greeting when we're going to. So I have worked in places sometimes where if you're busy, you might grab the phone and be like, hello, because you're forgetting. But if that greeting is something that you've rehearsed, you'll be okay with it. So what do you do for your rehearsal greeting? This is, you may end up saying things like, hi, this is Kelly. Can I help you today? Depends on what the dentist wants you to say. Sit up straight and smile. Yes, you can hear this in someone's words. So your main job is to listen when you answer a phone call. Have a plan for taking notes. I need to have a piece of paper beside me all the time when I'm on the phone. And if your caller is angry, don't give them the same tone back. Change the tone to calm. Transfer the call. Arrange a callback time with care. If do your best to deal with it right then. Don't put them off. They just get angrier usually. Abusive callers. You do not need to take abuse at work from a caller. If someone is swearing at you or they are being threatening, you say, I'm going to disconnect this call now, and you hang up. It is difficult not to lose your cool. I hope you notice that, because I might, in my private life, have not said lose your cool. And I want you to see that when you are in a professional situation, you use different words than you would in your private life, even though the meaning can be the same. So, being calm is a big part of your phone technique. Try and remember that even the angriest of callers likely isn't angry at you. And even if they are, it's your work life. Yes, it can have a great effect on your whole life, but only if you deal with it in a combative way. So try. It's not easy, I know. I'm not preaching, I'm just giving you advice, things I've learned over the years. Interact successfully, be an active listener. Some people respond well to tone and touch, and others do not. It all depends. So, what I do with most populations is I repeat the speaker's ideas and I ask open-ended questions because this gets them talking. So if somebody comes in and they say, this denture doesn't fit me and I'm really unhappy, I am likely to say, so you're not happy with your denture? Well, yeah. Yeah. And then you can go on. Why aren't you happy with your denture? Well, it hurts me back here. Then I know that I can, address that with the patient. It gives me guidance for, you can also ask them for advice. So what would you do if you were me, as in, how would you like the dentist to fix this today? And that supports and validates their feelings, and makes them to be a partner in their healthcare there. When we say special populations with tone and touch, if someone can't hear you, you have to gesture, and you will have to, use closed questions that people can nod their head to, or shake their head to. Remember that 60 to 70% of our communication is nonverbal, meaning that people pick up quite a bit from our facial expressions and our eyes and how our eye contact is. And sometimes it doesn't matter what we say because they've already heard us with our body. I am a person whose most of my feelings show on my face. And so it does become a challenge to be sure that you're sending out appropriate nonverbal communication with patients and coworkers, because they can tell when you're mad. So you have to, So planning a successful career, follow the rules and regulations, be confidential, be discreet in what you disclose. You are prohibited even from repeating casual information outside of the dental office. Anything you overhear at work is confidential. If you hear the dentist fighting with his wife about something, you do not take it. Just because the dentist is not your patient, do not take it outside of work. It can be the best way to ruin a good thing. Records, accurate, consistent legal documents, don't forget that. Follow all the rules, make sure you have some goals. Be promotable. How do you be promotable? That's once you get the job. Critical thinking is being objective, removing your bias. Critical thinking makes you think on your feet. Positive relationship with your boss. Bring a solution to them instead of just a problem. And be open to constructive criticism. That's not an easy thing to do, but a lot of times and people, even when they mean well, sometimes they don't say it well. And so we can be likely to really react in a way of like, and you want to, it's always my first knee jerk too, is to react, but you don't have to react that way. You can actually look and see that they're trying to help you be better, or they're trying to get you to pay attention to something that they think you're not. And so it's okay to do that. To be, it's all right to take criticism and take it gracefully. It makes you better in the long run. Be accountable, be teamable, take ownership of what you do, commit to your profession, and make sure that you're not just looking at it like if you don't look at it like an overstop, then you'll do well. Your strengths: build self-esteem, control anxiety, practice resilience. I'm getting towards the end here. Manage your emotions, keep your work separate. You get more flies with honey. So more sugar will bring more of what you're looking for than being yucky. So your interview, prepare for your interview by rereading your resume. Make sure you remember what you put on there. Arrive 15 minutes early. Don't bring your best friend. Don't bring your boyfriend. Come alone. Dress in conservative business attire. Relax, act natural. Introduce yourself. Smile. don't give out too many personal details at once. Don't start telling everybody about what you did last weekend, even though it might be the greatest thing ever. You don't know these people yet. Just, be professional. Close with a thank you. Send a follow-up letter or email. That's really important. And don't give up. Sometimes you got to do a lot of interviewing before you find the place to be. All right. Example of a thank you letter. Thank you for taking the time out. I know why I'm going to be the best thing since sliced bread for you. And I look forward to hearing from you in the future. That's a thank you letter. Expect acceptance and give your respect to others. If you if you go in and be like, well, I know you probably don't want to hire me because I don't have a lot of experience, well, then they're going to not want to hire you. You want to expect that, I don't have a lot of experience, and so you can mold me into what you want to be, what you want me to be. That's a better way to sell yourself. Smile to break your barriers. Breathe deeply. When stressed, it takes 21 days to get a new habit. So if you're trying to get rid of swearing, give yourself 3 weeks to adjust to that new habit. So you're going to fall off the wagon a few times until you get there. Listen and adjust to self-talk and dress appropriately. These are going to open doors for you at work as well as in your personal life. These are really good things to sort of do. You're special. Act as if you are. And act as if you're the person you always wanted to be. So for instance, if you've done something in your past that you're not proud of, that you may even have to disclose because it comes up on a criminal check or something like that, you need to be as upfront and positive about that as you can be. And give respect to people and expect it in return. Be flexible. Act as if you are what you always wanted to be, because you are special. I have 2 minutes left here, and I will spend that with the job search documents. Let's see. Okay, it's going to take too long for me to get to there, but so this is just a template. So when you go into these things, you're going to see all these Latin words. Those are templates. You change those words to fit you. The one thing that I didn't attach that I wanted to was a sample resume. So I'm going to, like a dental sample resume. So I told you where to look for in the textbook to get your phrases, but I'm going to attach one with the person's information blacked out, so that you can see an example of a successful one, and that will be part of this. So if you want to, and the person that I'm going to use is also someone with little experience, and so it will help you to build, a resume that's centered around your education and focuses less on what you didn't do. You know what I'm saying? All right. So have a great week. Please, please, please make sure that you get in and do your Evolve. Everybody's behind. Come on, guys. We can do this, right? So have a great week.